Today is day 2 of Foundations, and I hope that you enjoyed the teaching yesterday. What we're going to do today is go over these different areas that we talked about yesterday around the Lancet article. So we're going to look at more areas with respect to children and adolescents. I know people had a lot of questions yesterday, and we saved them for today. And also we're going to talk about caring for people that are going for surgery. We're going to talk about ethics, and we're also going to talk about surgery as well, more in depth. We are going to have a session from people from Asia Pacific Trans Network in conjunction with them and the local trans activist organizations, asking about what the attitudes are and what the education is around transgender healthcare in Vietnam. So HauE will be here, as well as Joe Wong, as well as Cole, leading that session. Today I'd like to introduce our faculty that is present at this time. They'll be coming in and out during the day. Dr. Lauren Schechter, who's a plastic surgeon from Chicago. Dr. Maurice Garcia, who is a urologist from Los Angeles. Dr. Diane Arensaf, who is a child and adolescent psychologist from San Francisco. Dr. Steve Rosenthal, who's a pediatric endocrinologist from San Francisco. And there he is. And Dr. Scott Leibowitz, who is a child and adolescent psychiatrist from Ohio. So, without further ado, I'd like to, Lynn, did you want to invite Diane up to the stage?
First, can you all hear me okay? Can you hear okay? Yes. And I just want to thank you and tell you how honored I am to be here today. And one of the things I've thought about is that all transgender adults were once children. And also, many children start a gender journey very early in life. So I would like to share with you what I've learned in my work, and then hopefully later in the morning we can have time for dialogue and share also what you know and questions you may have of us. So, to begin, just to make sure we're clear about the terms and definitions I will be using, and I will say I will not get through all my slides in the time allotted, so I will stop when my alarm goes off so we can stay on schedule, and the rest of the slides will be available to you, and I will be available for dialogue. So we have gender identity, one identification as male or female, somewhere else on the gender spectrum that's inside ourselves. We have our gender expressions. That's how we present our gender to the world. We have our biological sex that is typically based on our chromosomes and also the appearance of our outer genitalia, and is usually designated at birth. We have gender dysphoria, and that simply means a discomfort with one's biological sex or the gender role assigned to a person. Oops, sorry. And we have all these different terms to refer to young children who are exploring their gender, and in English, these terms change about once a year to something new. So I just wanted to let you know that, but I just listed some. And then we have our sexual orientation or our sexual identity, and that typically has to do with who we're attracted to and would want to be with in a romantic relationship. And it sometimes also means not wanting to be with anybody. And just to take away from this slide is simply this, that you are typically beginning to get a hold of your gender identity well before you start to get in shape your sexual identity. It typically comes first, it overlaps, and sometimes the two come together, overlap, particularly beginning at puberty, but they are two separate developmental tracks, your gender and your sexual identity. Now, I'm going to tell you some things about developmental theory of gender, and I will tell you I learned some of this in school, and then I had to unlearn it to do good work with children who are exploring their gender. So what I learned is when I was going to school that your gender identity is established between ages 3 and 5. What I can tell you now is it may be established, but it may not. And those are simply variations on human life. What I learned was that at age 6, you should know your gender identity. And what I learned when I was growing up, that if it is normal, that means it will match the sex designated to you at birth, and also that you can't trade it for another identity. That's what I learned was healthy development. And I will tell you that's not true. That some people will not have finished their gender journey at age 6, and some people will definitely have finished it, but it will be a gender identity that may be a surprise to their parents. And you can move from one gender to another as a healthy person. Now, traditionally, it was also believed that your healthy gender development would mean that you had a gender identity that matched the sex designated at birth, and that you would be heterosexual. That also does not hold up in practice, that healthy gender development comes in all varieties and in all different ways of who you want to be with. And so since the theory doesn't hold up in practice, we had to make new ones to be able to do our work. So we have new research and new thinking about gender identities, and that we have the work of one of my colleagues in the United States, Christina Olson, who has really helped us understand that there are children very young in life who have a gender identity that is different than the sex designated at birth, and that when they get parental support for that gender, they're doing fine, and they're doing just as well as other children. Oops, let me just... Okay, so here's the relearning, the theory of gender development that I hope you can take away with you today. That the sex designated to a child at birth may not be consistent with the gender they know themselves to be. That gender identity development is not necessarily binary or fixed at age 6, but may be a lifelong evolutionary process. On the other hand, there is a subgroup of children who are capable at a very young age of establishing a stable and long-lasting gender identity that does not match the sex designated to them at birth, with comparable psychological standing with their cisgender, that is, having the same gender that matches the sex designated at birth, peers. And that gender identity is absolutely to be differentiated from gender expressions, and I want to underline that, because those two are often collapsed. And we as providers have to learn how to differentiate gender identity from gender expressions. Who I am from how I do gender. And that I mentioned before, our sexual identity is a separate developmental track. Now, I, in trying to relearn gender, made something up that I'd like to share with you that I hope will be helpful to you in understanding both a child, but anybody's gender development. I call it the gender web. We came up in the West of a term, the gender spectrum, which I thought was great because it meant one's gender could just be so varied with an infinite number of hues and variations, but it's very linear. It's male on one side, female on the other. So I thought, how about something three-dimensional? So imagine a web, like a spider web, in a tree that spreads in different directions, and you can come up with the gender web. So let me explain. So this is the weaving together of nature, nurture, and culture over time as a child develops their gender. And the threads in the gender web, when we break down nature, nurture, and culture, are many. For each child, you have their chromosomes, their hormones, their hormone receptors, their gonads, their primary sex characteristics, their secondary sex characteristics, their brain, their mind, their socialization, family, school, religious institutions, community, their culture, their values, their ethics, their laws, their theories and practices. Now, society absolutely has an impact on gender development, so we have to be culturally sensitive and know what culture a child is growing in to understand their gender development. So I want to share with you, let me just go back for a moment. This is, I couldn't get that slide to stay, but I wanted to share you my first book that I wrote at age 13, first a school assignment, and it was a book called Who Are You? And I basically said, I wanted to talk about what is your gender. And I think, here, let's see if we lost some of the slides, but I talked about your gender depends on the reaction of your parents. That's very important. And some of these slides, I talked about sometimes boys want to be girls, sometimes girls want to be boys, and that's okay. The important thing is that you grow up with a gender that you feel is right for you. I don't know how I knew this in 1960, but now we have, many years later, I came to this conclusion. I'm sorry, in 1960 I came to this conclusion, and this slide isn't showing up, but just that everybody should have a way to do gender the way they want to. At the time I was very envious of my older brother because he got to do things I didn't get to do because I was a girl, so I thought this would be a good conclusion for me. Now, let's look at the mental health of gender-expansive children. Okay, this is the primary mental health tenet about children's gender. It is not for the adults to say, but for the children to tell. It comes from within them. What the diagnostic manuals tell us that were designed in the East, so we have the DSM-5, which tells about what happens when that becomes complicated for a child. Then you might have something called gender dysphoria, and that is a marked incongruence between one's experienced expressed gender and assigned gender, at least 6 months in duration, manifested by at least 6 of the following: strong desire to be the other gender, or insistence that one is a member of the other gender. In boys, strong preference for cross-dressing or simulating female attire, and girls, strong preference for wearing only typical masculine clothing, and strong resistance to wearing typical feminine clothing. Strong preference for cross-gender roles in make-believe play or fantasy play. Strong preference for toys, games, or activities stereotypically used or engaged in by the other gender. Strong preference for playmates of the other gender. In boys, strong rejection of typically masculine toys, games, and activities. And in girls, strong rejection of typically feminine toys, games, and activities. A strong dislike for one's sexual anatomy. A strong desire for the primary and or secondary sex characteristics that match one's experienced gender. A strong desire for the primary and or secondary sex characteristics that match one's experienced gender. And then you're supposed to specify whether it also is accompanied by a difference in sex development. Now, this is a very controversial diagnosis. Number one is a mental health diagnosis that suggests, therefore, that there might indeed be a mental disorder. Whereas it can be very helpful to help youth get the care they need, it can also be used to designate that they have a disease. So there is a controversy in the field worldwide whether there should be such a diagnosis or not. And in the new ICD, there will be no mental health diagnosis. It's taken out of that chapter. But I think we should all just know what people are working with and the diagnosis that stands. Now, what the research tells us, that mental health of transgender children who are supported in their identities is good. That when there's been a match sample, the kids look just the same as the kids who were not transgender. In this case, it was a group of young children who had socially transitioned from one gender to another. And what was found was everything was within quote-unquote normal limits on the measures used. Now, I wanted to just share with you just a clinical case from California. And this is a case of the rainbow kid. And this is Jordan, 7.5, has been seen periodically by me since age 5. Parents first made contact when Jordan was 5. They were preparing to enter their child in kindergarten, but they didn't know whether to enroll Jordan as a boy or a girl. Jordan was designated male at birth, had originally said he preferred she and her as pronouns, but did not want to go to kindergarten as a trans girl, just a girl. Jordan's preschool teacher recommended that Jordan's family seek out the help of a gender specialist. First 3 months were devoted to parent consultation. I never saw Jordan, I just worked with the parents. And then I began seeing, that should be Jordan, I'm sorry, with mother in the room, periodically to the present. Family constellation, that's skipping, but it's mother, father, a younger brother, and a younger sister. And Jordan expressed discomfort with being a boy since age 2. He said, "I wish I was a girl." Since early childhood, Jordan had always loved sparkles and for the most part wore gender-neutral clothes. For a long time, Jordan's favorite color was purple, but then went to pink. When his sister, whose favorite color was also pink, began getting pink things in ballet costumes, Jordan coveted them, so the parents bought the same items for Jordan. When his youngest sibling was born, Mom read Jordan a book about birth. Jordan became distraught, crying. Jordan did not have a uterus. Jordan announced, "I'm going to cut open my body and put a uterus in." Jordan's fantasy at that time, when Jordan grew up, Jordan was going to be a mommy, and fantasy play with his sister, Jordan played the mommy. At the same time, when the youngest brother was born, Jordan was very interested in the little boy's gender, and he expressed excitement that both Jordan and the new baby were both boys. Now, here's Jordan's gender at age 5. Jordan wore clothes with a range of colors, but wants underwear with special designs. At the clothes box at school, and that's available for kids who need a change of clothes, Jordan will always sort through and pick out girls' underwear and shirts with hearts and stars. When Jordan visited the elementary school, Jordan would be attending in the fall. Jordan went into the kindergarten dress-up box and picked out high heel shoes and jewels. After Jordan's 5th birthday, Jordan became more adamant, declaring, "I have a boy body and a girl brain." Jordan's parents had read "I Am Jazz" to Jordan. There were some co-occurring issues going on for Jordan. There were speech problems, there were sensory motor issues, there were some social issues in terms of getting along with others and expressing themselves. And there was impulsivity, a little bit like a jack in the box at home, bouncing up, especially since the birth of the younger sister. Developmental history, Jordan was born early at 34.5 weeks, suffered from reflux response, made little eye contact. At 9 months, parents sought out the services of a renowned infant specialist who worked with Jordan for 2 years. Upon entering preschool, the parents transferred their services to an occupational therapist who Jordan sees to date. So this is a child who's gotten many interventions very early in life. There's been a trauma. Jordan was circumcised at birth, but there was a problem with the circumcision, with the skin adhesion, and Jordan had to be recircumcised at age 3. After the second circumcision, Jordan began having wedding accidents at school. By age 4, Jordan did not want to use any bathroom and said, "I don't want people to know I'm a boy." So the parents' concerns, is Jordan stressed about gender? How do you proceed with enrolling a little child like that in school? What gender? Could Jordan be just a quirky kid with sensory issues, and that's why Jordan was so rigid about gender? Jordan stands to pee, like typical boy quote things, rough and tumble play, trucks, rockets, but considers himself to be a girl. How do we make sense of that? Does Jordan have shame about Jordan's gender self? Here comes the rainbow kid. So this is a little child who came to me. We talked about school, and after we worked together for a while, I explained that his school, the teacher would ask what name and what gender pronouns they wanted to use on their little cubbies. And Jordan got really upset and just said, "My name is Gummy, and as for my pronoun, just call me Rainbow Kid." And then looked at me and said, "Got it?" And the history was that the mom had been asking Jordan every day, "What gender are you? What pronouns do you want to use?" And this was making Jordan increasingly unhappy. So Jordan teaches me what a rainbow kid is. Whoops. Not a boy, not a girl. And I wanted to just share you, except that the pictures aren't coming through here, but here. Okay. So these are Jordan's, he plays in the sand, or they play in the sand, and this is what Jordan made for a scene in the sand, 4 princesses and a long march, and the story goes like this. Once there was a little princess, and then another, and there were 4 princesses and 1 girl, Dorothy figure, who Jordan took off the shelf and asked, "What is this, a girl?" And then they walked for a very long time, for 50 miles. And then here's Jordan at age 5. Oops. And let's go back here. Okay, so this is Jordan, who just lines up princesses and at the same time picks out this kind of a figure, both of which represent Jordan. And let's see, okay. Yeah, it's not showing the, we'll keep going forward. Okay, so the one thing I think you should know that comes, what we've learned over the last decade plus, is the issue around desistence or persistence of a child's gender in early life. And there was research done in the Netherlands with young children who came to the Amsterdam clinic that looked at 2 groups of children, some who early in life were at that time given a diagnosis of gender identity disorder. And what they found is, as they followed those children through time, that the majority of the children were D-sisters. And they were young children who receive a gender diagnosis early in life, and they don't have it anymore by the time they reach puberty. And then there was a group called persisters, who were young children who receive a gender diagnosis early in life, and then they persist with that diagnosis into adolescence. So we have D-sisters and persisters that were identified as 2 different groups in the research done. And it was approximately, the last count was 63% of the kids that came through and were in these studies were D-sisters. So I want to just, in English, I want to mention something about the language used when it's in English, which is this. In English, to persist in something, we encourage persistence in our children. But we can also find it annoying if they persist to keep doing something we don't want them to do, and we want to get them then to stop. To desist in English typically refers to a behavior or a habit that we want our children to stop doing. Desist. So when we talk about persisters and desisters and use that language, it has implications that in either direction there may be problems. And I would say that language shapes our thinking, and we might want to then desist with this language and not use it. Because of the negative connotations. And there's also problems in this research, and I highlight this research because it's used now to basically argue against young children being able to articulate and live in their authentic gender. And the methodological concerns in the research were this, that they really lumped all the kids together in one group at the beginning and if they simply had to qualify by having this gender identity diagnosis, a gender identity disorder diagnosis, which is the diagnosis of the time. And then they didn't do what I said before was the most important thing we do to understand children, which is to differentiate the gender identity, who I know myself to be as male or female or other, from how I like to express myself in gender. And if you clump the two in clinical work, you may make mistakes. But if you can recognize them separately and then bring them together, you can more likely get a child in focus and find out who they are. So we have collapsing the kids who were perhaps saying, I am a boy or I am a girl, from the kids who were saying, I'm not sure, I'm just exploring. So they were all put in one group when they were little. And then the variable used to measure whether indeed they persisted is whether they had medical intervention. And we know that some transgender people don't want medical intervention, and therefore might be put in the desister category. And they're indeed persisters, but they just choose a different way to put together their gender without hormones or surgery. And also, there were people who didn't show up at the clinic anymore throughout the time they were looking at the children, and they counted those children as desisters. In research, you can't do that. You can't count people who fell out of the study as in the study in a certain category, so that would essentially contaminate the research. So what we have now found is this, that we can identify children early in life who may be, using the word gender dysphoric, identifying a strong sense of gender dysphoria. And we are going to be able to identify earlier in life that these children, most likely, we can never guarantee, have a stable gender identity that will carry through life and that we should attend to it. And even if they don't, is at that cross-section in their young life, they are telling us in word and deed, this is the person I am, please let me be that person. We are finding that they do better if we listen, as long as they have social supports to be able to do that. So I just wanted to talk to you then about what we call gender social transitions for children under the age of puberty. So defined as a shift from the gender that matches the sex designated at birth to a different gender that a child identifies as more consistent with their internal sense of self. It can include a change in name, gender pronoun, manner of dress, or appearance. And obviously that's going to vary from culture to culture, and I'm learning a little bit about how it is in Vietnam, about names and gender markers. In the United States, a child can change their name and their gender marker legally. The most important variable that we are looking at here is that this is a child communicating that they are wanting to be living in a gender that feels right to them, even if it's confusing to other people. It cannot come from somebody else doing it for them or to them. It has to come from them and having other people help them with that because they're children. Now, sometimes it can be what we call a full transition. The child changes in every place in their life to the gender they say they are, perhaps choosing a new name, and perhaps saying, please, my new pronoun is she, not he, and my name is Jennifer, not Jeff. But it can also happen in just small circles. So protected situations, and they may have to do with family issues, it may have to do with community issues, it may simply have to do with the child's choice of how they want to explore their gender at that moment in their life. And it can happen at any time during a child's growing years. Sometimes it's believed that if a child isn't one of those children who what we call consistent, persistent, and insistent from early in life, then they don't count. They're not a true blue, small transgender child. And that is not accurate. That is one subgroup of people. And there are other people who don't discover till they're 50, 70, or 80, or somewhere along in childhood. And often puberty is a nodal point when your body starts to change. That's often a moment where there's an aha experience in a child of something's not right for me. And then you'll be hearing more about that from Scott when you talk about adolescence. And typically it is predicated on parents or caregivers offering support for that social transition. Now, why are they controversial? Social transitions are a very controversial thing at this moment in history around the world. And it comes up like this. Can a young child really know their gender at age 4? And what if they change their, what if they're just sisters? And what if they change their minds? What do we do about that? And what if we box them into a gender that they're not going to feel comfortable exiting later? Like, now that I said it, how can I go anywhere else after everybody went through all this work and I changed my gender? Now, I wanted to share you a little bit about what we have initially found in the study that we are doing among 4 sites in the United States. And our site, University of California, San Francisco, is one. And there's Children's Hospital Los Angeles, Boston Children's Hospital, and Lurie's Children's Hospital. And what we are looking at is the medical and psychological outcomes of puberty blockers and gender-affirming hormones in youth. And so the question I was particularly interested in about social transitions is we have a group of children who come in, who would join the study because they're just leaving childhood, beginning puberty, and they are choosing to start on puberty blockers as part of their gender journey. And we're measuring what they're looking like at baseline before they start blockers. And we found something very surprising. And that, according to our study, a surprising majority had socially transitioned already. Let's see if I can. Okay, here it is. So what we had is we had this many. So we had 81% of our sample across the 4 sites had already either totally, socially, completely or partially socially transitioned before asking for any medical interventions. So we have a large group of kids who have seen pretty clear before they reach puberty that this is the gender I am. We're still following to see if they change over time, but we did not expect to find so many, this 81% of our sample having already socially transitioned. The debate is this: the arguments for social transitions, it can alleviate immediate psychological distress. It can help to affirm and support a child's desire to live in the other gender earlier, should that be desired. And it allows a child who may be transgender in the future to live authentically from an earlier age. And one of the things I will say, this is just my clinical observation, in terms of the arguments for, is there's something called the ex post facto test. And it goes like this. There's a child who's saying, I'm really unhappy, I'm not the gender you think I am. Will you listen, and will you let me be the gender I'm telling you I am? And that child often has some symptoms. They're angry, they're anxious, they're afraid to go to school, they have trouble sleeping. There are many things. They don't concentrate in school. And then, if somebody says, okay, I understand, and they then socially transition, the symptoms either go away completely or they diminish markedly, even in the face of the kind of gender minority stress they may find in the community. And I've been a clinical psychologist for many, many years, and in all my work with all kinds of kids, I have never seen such a dramatic shift in well-being than in those children who are listened to and given the supports to transition. It's been a very moving thing for me and a remarkable thing for me. But there are certainly arguments against it. That we don't know, as I said before, whether we'll be boxing kids in, because kids are moving quickly on a trajectory of development where things change much more rapidly than for us adults. And so what if they change over time? And that maybe we're also developing in children keeping secrets syndrome, where they're afraid to tell anybody what their body looks like, and so they live with that stress all the time. And will there be indeed a whole lot of challenges if they want to evolve to a different gender later? And so should we be very conservative and keep that in mind? So, as I'm just going to repeat what we found before, was that the kids are doing okay, and that I will say one thing from that's Christina Olsen's, and from our research, what we found was that we made a hypothesis that if the kids had transitioned for 3 or more years before they arrived to taking puberty blockers, they might possibly show more positive psychological functioning compared to the youth with fewer than 3 years of social transition. So the longer they had living in their authentic gender, the better they would be doing. That was our hypothesis we tested. And here's where it proved to be true. I'm having trouble holding the one. Okay, you got it. Okay, on self-efficacy, on positive affect, and in general life satisfaction, there was a strongly significant difference for the kids who had had more than 3 years of social transition versus the kids who had less than 3. And this is among the group who had all socially transitioned. But the longer you were, the better you did. So what do the kids have to say about this? When the kids were asked about their lives, the only significant difference between the two groups was on school functioning and their quality of life. So what they said was this, that if I have been socially transitioned for more than 3 years, I feel like I'm really doing better, I'm doing well in school. And there was a significant difference between the two groups. So the more time you gave a child to socially transition, the better they felt about how school was going. And these other things, no significant difference on emotional functioning, physical health, psychosocial functioning, or social functioning. So it didn't matter how old the child was when they socially transitioned, only how many years they had socially transitioned. So when is a social transition for a child appropriate if we think about gender development? First, we do rule out other possibilities. Gender can be a symptom of some other underlying problem, and it can be a solution to another of life's problems. If we determine through careful thought that the central issue is gender identity, not gender expressions, and when the child expresses a need or desire to transition, when the parents or the caregiving environment can offer positive support for the child transitioning, then a family can consider a social transition either everywhere or in safe situations. And we'll be talking about working with families tomorrow, but this is an important component because, as we know, many families are not going to support this. And so that's working with parents is extremely important. And we also know that it isn't safe for many. 9:30 I have? Do you want me to stop now? I have 5 minutes. I have my alarm set. Okay. But I can stop now if you want me. Do you want me to stop now or when my alarm goes off? Okay. Okay, so I'm going to just skip to that and just say, do we need a doctor in the house? All right, and I want to finish with that message. And this is the working statement from the new WPATH Standards of Care 8 Childhood chapter, which I am a member of. And this is what we decided as an international group about what should happen for young children. Children who are gender diverse and their families do not always need the input of mental health providers, since gender diversity is not a mental health disorder. However, guidance from mental health providers or others with relevant experience in this field can often be helpful. So, involving mental health providers is recommended by the Endocrine Society, the American Psychological Association, and the American Academy of Child and Adolescent Psychiatry, and the World Professional Association for Transgender Health in our standards of care. So, my final points: every child's unique, has a unique gender web, and every gender journey is unique. There's no way to accurately predict an individual child's gender trajectory over time. We do not have a blood test. We do not have a brain scan, but we do have some careful assessments we can do. There are many transgender adolescents and young adults who are not exploring gender outside of boxes as children, and there are some children who are gender diverse, even socially transitioned when young, and do not continue on this path. The bottom line: to promote children's gender health, adults, parents, providers, teachers, etc., must remain open to each child's gender journey and not box children in. For professionals, this is complicated work. It's rewarding. It's the best work I've ever done, and it's really challenging. Therefore, seek consultation, get training, get professional support for the rest of your life, because I'm always learning, and what I thought I knew yesterday, I won't work tomorrow. And we will have questions later at the panel, because I understand there's some questions, and thank you very much.
Vâng, xin cảm ơn tiến sĩ Diane Arenshaw vì đã chia sẻ về những kiến thức nền tảng về phát triển giới ở trẻ. Vâng, sau đây sẽ là bài trình bày kiến thức cơ bản về chăm sóc sức khỏe tâm thần cho trẻ vị thành niên chuyển đổi giới tính bởi bác sĩ Scott Leibowitz. Sau đây tôi xin nhường lời giới thiệu cho bác sĩ Lynn Fraser.
Hello, and I would like to introduce Dr. Scott Leibowitz. Dr. Leibowitz is a clinician, an author, an expert witness, and I would say very well known as an educator. His goal, one of his professional goals, is to train providers globally, such as yourselves, on working with children and adolescents. He is an author, an expert witness, and director of Thrive Nationwide Gender Development Program. Thank you, Dr. Leibowitz.
Thank you. and good morning. My name is Dr. Scott Leibowitz. I am a child and adolescent psychiatrist. So as a doctor, I am the doctor of the mind and body connection. And so for transgender people, when that mind and body connection is not congruent or not matching, my role is obviously, hopefully, very relevant. So I wanted to take some time first just to say thank you for having me here in Vietnam. KHauE moi noi dao de. And with my welcome, I wanted to also say thank you for coming during such a special time today, because I realize that it is the Vietnamese New Year, and I had the opportunity to really learn about the different parts of Vietnam. I spent 5 days in HUİN before this. And I saw many of the trees that people are bringing to their homes for the New Year. So Happy New Year to everybody. Okay, so adolescence, we all just heard from Dr. Aaron Saft about being children. Now we are all going to go into puberty together and become adolescents, okay? So that could be a very difficult time for every single adolescent, but it's a particularly difficult time for adolescents where puberty itself is making changes to their body that is difficult for them. So this cartoon says, the puberty fairy, I bring social anxiety and hair. And I think that social anxiety for sure is something that many of the adolescents we see are experiencing. It's important to know that these issues, particularly within Western culture, and I also imagine within Vietnamese culture, bring ethical challenges and dilemmas when we as providers, as doctors, as mental health clinicians are helping families and helping youth make decisions about what to do. And so today I am going to go through several of the different ethical dilemmas. The first is, as you heard yesterday from Dr. Rosenthal, puberty suppression. That has pros, that has cons, and we need to understand the pros, we need to understand the cons. Then medical and surgical factors. Some people say, ooh, these are adolescents. They are too young to make a decision about these irreversible changes that happen to the body. And so how do we figure out what's best for an adolescent? Another ethical challenge is doing the assessment, okay? Sometimes people say that we need to do a very, very strong assessment using instruments and psychological measures, and others say we don't need to do any assessment at all, and both are too extreme, okay? We need to think about how do we assess an adolescent's ability to make a decision, and today I will talk about the dilemma. Tomorrow we will talk all about the details if you come to the child and adolescent section tomorrow. And then another ethical dilemma is, when do we start? When should we start these changes, these medicines? And what happens if an adolescent has other issues psychiatrically that they are experiencing? Sometimes the psychiatric issues can make it difficult to understand if the adolescent can make a decision. Other times, being transgender and experiencing the stigma associated with this very difficult experience in society causes a mental health issue. And our job is to figure out which is which for each person. So I'm going to put this image up because I don't know if you have it, but this image on the other screen is important because it is something that different people have different perspectives when approaching very complex issues. So if someone on the left is looking at the shape in the middle, they see a square surrounded by an orange circle, and they believe this is true. And guess what? They are right, because it is true from their perspective. But then if you look from the people on the right, looking at the same exact shape, they see a blue circle surrounded by a blue shadow. And they say, well, no, this is right. What I see is right. And guess what? They are also right, because what they see is also true. However, the real truth is in the middle. And we as professionals need to understand that we only see one side of things. There's also been increasing complexity in the youth that are coming to us. Oops. So the complexity I will talk about, but kids are coming in feeling different genders on different days. Kids are coming in with other psychiatric issues like autism or even severe depression. And so sometimes it can be very difficult. We are seeing kids who present where there seems like no childhood indicator of being a different gender, and then in adolescence, puberty hits, and all of a sudden youth are feeling, ooh, I might feel like a different gender. So things are becoming more and more complex every day. We are also seeing an increase in the amount of clinics in the United States and the world. So in 2007, there was one or two main clinics that were really formal in a pediatric academic medical center. There were many providers doing this work, so I don't want to say that there were nobody was helping. People in the audience even, like Dr. Ahrensaf, Dr. Rosenthal, but there were only a few clinics. Now we have almost over 50 clinics in the United States in 10-year period. So you can see there are people that need help. It's also important to know that different clinics use different models of care. Some clinics are in a medical setting, some clinics are in a mental health setting, and other clinics are in a mental health and medical setting. And the guidelines that Dr. Ahrensaf posted at the end of her talk, most of those guidelines suggest that a team approach is helpful so that we have many perspectives. So here's the increasing clinical complexity. For example, some of these are like my patients that I was treating. A 14-year-old assigned female at birth with many medical diagnoses and a long psychiatric history, who comes into clinic and says, I am gender fluid and I am pan-romantic. These are newer terms that we had to learn. And I only want chest surgery, no hormones, just chest surgery. Or another patient who's 17-year-old assigned male at birth, who identifies as female. She is self-injuring by cutting herself, has parents who are refusing to acknowledge that she is female, and she is skipping school because at school the teachers are not using female name and female pronoun. There's also a 15-year-old with autism spectrum disorder who is an assigned male at birth, who wants me to use the middle pronouns, they and them, because they are a non-binary, bigender, agender, female, panromantic, asexual. This was new to me. And threatens to self-injure if you don't say their name, and they want estrogen to grow breasts just for the days that she feels female, but on the other days she wants to wear a chest binder so that you don't see her breasts. This is complex. Or a 16-year-old assigned female at birth with a lot of psychiatric issues, including an over-identification with pathology in general, who feels transgender but has not made any steps towards wanting to be perceived as her affirmed gender. And why is that important? She might feel like a female inside, but her parents don't understand it because they say, if she feels like a female, she should act like a female. And it's my job to help translate between the parents and the kids, because sometimes teenagers don't feel comfortable expressing themselves when their body doesn't feel correct to them. So I want to go back to that original slide and say to you that there are some people that believe this is all just social change. People are influenced from the internet. Okay. And I think that that is an extreme way of thinking. It is not the full truth. Okay. And then there are other people that are saying, well, every single person understands who they are no matter what. So if they come in and they want a hormone, they need to transition immediately. And again, I think that the truth is in the middle. Now we're going to move through the ethical challenges and the clinical approach. So you already heard from Dr. Rosenthal about the medical aspects of puberty suppression, okay? However, puberty suppression, the benefits are psychological. And as a psychiatrist, I want to share my own thoughts about this. I might be repeating what he said yesterday, so I apologize. Basically, what we do is we wait for kids' bodies to start to change, okay? And then we use puberty blockers to hit a pause button, like we hit pause on the music, okay, on the radio. And by hitting pause, we are giving a chance for individuals who feel like their bodies are going to be changing irreversibly for that not to happen. That helps buy time for younger teenagers, because teenagers go into puberty very young, around somewhere between 10 and 12, but it could be 9 to 14. I mean, the average changes it's different for different youth. And that early is very difficult to make a decision on irreversible changes from hormones. So when we buy time, okay, then we can explore the kids' decision-making capacity. We can explore their ability to understand their identity, understand themselves. And when you give gender-affirming hormones after that, what you are doing is you are promoting a lifelong perception of one's body being perceived correctly as the gender that they identify as. So you can see on the top is male puberty is stopped, then they explore, and then if you give hormones, not every kid wants hormones maybe, But if you do give hormones, then their body produces a puberty like a female puberty, okay? And for the bottom, if you block female puberty and then you explore, and then you give testosterone, you produce a male puberty. So this helps people feel like they don't go through the puberty that they do not feel matches their mind. For example, it also minimizes invasive procedures. So a trans male, if they don't grow any breasts, they don't need to have a breast surgery later on. Does that make sense? There's also some risks, okay? Actually, that side is wrong. It should say risks, okay? Not benefits. Right now, the endocrinology team, they talk about bones, okay? I'm not an expert on bones. I think some people are worried about bone development, but I know that there's research that shows that if you give the hormone after puberty blockers, bone development catches up. There's no fracture risk proven. So this isn't such a big risk, but it's something to think about and talk about with the team. What I am concerned about, but a little bit, is brain development. Kids are supposed to go into puberty at this time, and hormones affect the brain. There is some research that shows that puberty suppression, when followed by hormones, that it does not negatively affect the brain. But the research is small, and the research is still evolving. So we can't, we have to still look at what is the research will come in the future. And we also have to understand that the research right now is only looking at kids who don't have brain issues already. And so we need to expand the research to include youth with neurodevelopmental issues, such as ADHD or autism spectrum disorder. Something that I think was brought up yesterday is, particularly for the trans girls, when you block puberty, you prevent penile growth, and we have the surgeons here to talk about this after. The problem that we are trying to figure out is if we block penile growth in a young adolescent, if they want to have surgery later to create a new vagina, sometimes the surgeon feels there's not enough tissue to do a penile inversion vaginoplasty. So it is important for me to talk with the parents about their 11 or 12-year-old's future maybe vagina. That is difficult. We also have to talk about the reproductive system. Puberty suppression pauses reproductive system from maturing, okay? Now, if we stop puberty suppression, the reproductive system continues. But if you go from puberty suppression direct to hormones, there might not be a chance to preserve fertility. And so these are conversations that we have to have with the parents, with the kids together. Okay, we have to respect everybody's wishes, and we have to meet alone with the adolescent to understand, does the adolescent understand what is going on? What is more important to them? Many don't want children. Many say, I don't think I want children later. But maybe they will change their mind, we think. So we have to help them understand, you might change your mind in the future. How are you going to deal with that if you change your mind? Just because we believe that reproduction is important, that doesn't mean that we need to put our values onto the family or the adolescent. We just have to give them the information and help them come up with their own decisions. And I also want to just point out that puberty suppression helps people look like a different gender. Is the goal to produce the ideal man or the ideal woman? And I don't know if that's a philosophical question. Is that our job to do or not? I think puberty suppression is very important, but I think we need to make sure that it's helping the individual and that we're not trying to make society different, or we're not trying to conform to society about what is the perfect man and what is the perfect woman. There is evidence that shows the psychological benefit of puberty suppression. So this is not something that we are doing as an experiment. We are doing this with research, and it is important. Oops. Now I move to hormone decision making. Okay, sorry. Sometimes this is not working that well. In the WPATH standards of care, this is what it says about making hormones. Okay, yes, that's the slide I want. Okay. In the past, historically, it said that age 16 is the minimum age to start hormones, okay? But the Endocrine Society guidelines have lowered that age to age 14 years old, and even 13 and a half if there is a compelling reason. Now, some of you in the audience might think, whoa, that is very young for adolescents to make a decision. How can they know? And I even talked with a woman in GIện, where I had a coffee with her, a Vietnamese woman, and we became friends. And we were talking about my work and why I'm in Vietnam. And she said, I'm pro-transgender people. I believe in helping everybody, but I think that you need to be age 18, not below. And I explained to her, if we look at age only, we are not doing a good job. It's about maturity. Not every person at the same age has the same maturity. There are many mature 15-year-olds. They're very immature 18-year-olds. Okay? How do we know who's mature and who's not mature when they are young? Okay? And I think that that's our job. We are experts in helping understand maturity. If an adolescent can make a decision, that's the goal here. And if you think about it, waiting until age 18 is very different from the rest of the population. A not transgender adolescent does not wait until age 18 to go through puberty. And we don't say to them, oh, you need to wait until you're 18 so you know that you can go through puberty. They go through puberty naturally much earlier than that. So if you wait a long period of time, you're not helping the adolescent feel comfortable with who they are. And that really, really has a negative effect on mental health. So the WPATH standards of care talk about, is this something that is going on for a long time? Does the adolescent have the capacity to make an informed decision? Age is one factor, not the whole thing. And also making sure that the psychiatric issues, if they exist, are controlled. Okay, if someone has major mental health challenges, we need to treat those first. Also with surgery, there's many surgeries, okay, that people get. For adolescents, the only major surgery that we think about is for the trans boy. So assigned female birth, transition to male, to have their top surgery is what we call this. This is a mastectomy, okay? This surgery can be very important for an adolescent because many adolescents feel, especially after they start taking testosterone and they grow a beard and their voice lowers and they look like a man, they still have breasts. And this can be very difficult to have one set of male features and then still have the chest. So doing surgery for a minor is important sometimes. Again, it's about maturity and it's about making sure that the adolescent understands what they are getting involved in when they go for surgery. And there is, again, research to show that there's low regret rate for chest surgery in adolescents coming from the clinic in Los Angeles. Oh, sorry, this is, okay, there we go. So, back to the same exact slide that I showed you earlier. There are people that say, there's a low regret rate, so you must do surgery for everybody. And then on the other side, there are people that say, minors, they're too young to do surgery, how can they do surgery? Both are extreme opinions. The real truth is somewhere in the middle. Now I move on to assessment. So I already mentioned that there's a lot of different types of youth that are coming and seeking help. They want hormones, they want surgery, and it can be difficult because we need to assess them to understand how well does the adolescent understand themselves. So usually when I meet with the adolescent, I say, hi, I want to explore this with you and help understand you. But adolescents, we all know teenagers. Teenagers, they don't think they need help. If a teenager says, my favorite color is red, and I say, no, your favorite color is green, the teenager says back to me, oh yeah? My favorite color is not just red, it's blood red. Okay? So teenagers always want to say the opposite, okay? So I have to become a team with the teenager, okay? And instead of saying, I'm here to assess you, instead I have to say, I'm here to collaborate with you and become a path paver. Does that make sense? Okay. Oh. So, wait, there we go. So again, this is the same thing of different perspectives. The patient says, I know my body, I know what I need. Okay. And the doctor says, well, I need to understand you before I can prescribe. Okay? But the truth is somewhere in the middle. You have to be a team. So what do we assess? How do we do initial assessment? First, we want to get a big picture of the adolescent. Like understand biological factors, psychological factors, social factors, okay? The way we would do with any other adolescent or child that is coming to the doctor for mental health help. We need to develop trust and understanding, both with the parents and with the adolescents. And both need to share their perspectives, so you need to meet with them separately. We need to explore their childhood history, as well as their recent gender identity declaration, in a non-pathological manner. So tell them it's okay to be whoever you are, and then that helps them tell you their true feelings. We need to also look for any other not gender-related psychiatric issues, maybe like anxiety, depression, eating disorders, autism spectrum, any other mental health issue, to see if that is something that is interfering with our understanding of the adolescent. We then want to think about, does this teenager know themselves well? How does that impact themselves and how well they know their gender? Okay, so do they know themselves as a whole person, and then what does that mean for their gender? And then we identify goals of treatment. So sometimes we need to address the psychiatric diagnoses first. Sometimes we need to figure out what do we need to do to become more clear, and then that helps us with an initial direction for the gender-related treatment that they seek. So we use the DSM in America, but I know in the rest of the world we do not use the DSM for mental health issues. We use the ICD. But in the DSM, for gender dysphoria of adolescents, you need 2 of the following 6 dots. So over a 6-month period, you need 2. A marked incongruence between one's experienced gender and their body, their primary or secondary sex characteristics. A strong desire to be rid of their primary or secondary sex characteristics because this does not match with their experienced or felt gender. A strong desire for the primary or secondary sex characteristics of a different gender. A strong desire to be of a different gender. A strong desire to be treated as a different gender. Or a strong conviction that one has the typical feelings and reactions of a different gender. You need 2 out of 6 for 6 months to meet the criteria for this. Okay, but again, this is a very United States-based classification. It's important when we are working with adolescents. In English, we use pronouns that have different genders. Okay. So I don't know about Vietnamese language, but we have to use the name that the adolescent chooses. We have to use the pronouns that the adolescent feels matches them. And again, I ask you, how is it different in your culture? And again, sometimes the parents are using different pronoun and name than the teenager, and that can be very difficult. So we have to separate the parents and the youth and work with them differently to help develop a relationship with the parents and respect the parents, and then develop a relationship with the kid and respect the kid, so that then we can help them come together and understand each other. So there's many areas that we can explore gender, 4 main areas. I'm not going to go into all of this because it's too detailed. The point here is that there's gender identity issues about how one thinks. There's gender expression issues about how they express themselves through the clothing, through the way they wear makeup, or through the way they just present themselves in society. There's the environment, whether it's a supportive environment or a not supportive environment. And then there's how adolescents cope. Some cope very well. Some adolescents are shy and they keep it inside. Some adolescents are rebels and they do things that are against their parents' wishes. We have to understand these factors. But if we only look at these issues, we're not doing enough. We have to also put them into the context of the full person. So what about the adolescent's hobbies? What about the culture? What about the language? How do they think? What is their ethnic and racial identity? Maybe in the farm towns of Vietnam is very different than in the city of Vietnam. Okay? Maybe the different religions experience this in a different way. So we have to understand the whole person to help the family. So these are some art pictures from my team, from my patients. Okay, I would ask for you not to take the pictures of my patients' art because they did not give me permission. They gave me permission to use, but not to share with everybody in a picture. This is a assigned female at birth who identifies as a boy. And here you can see it says, "You'll never pass." So that's someone saying, "You'll always look like a girl." And the boy on the right is crying because they want so hard to look like a boy. I think art is always very helpful to understand how adolescent thinks. Again, this is another assigned male at birth. I'm sorry, assigned female at birth, who identifies as male. And you can see they are ripping off their breasts to show their real chest underneath, what they wish they have. This is the opposite. This is a transgender girl, from male to female. She's being reborn into her new body. This is a very powerful image. This shows how much emotion these youth experience. And then this is also an adolescent looking in the mirror and seeing a different person. And this is an adolescent who doesn't feel male and doesn't feel female, but feels in the middle. We call this gender non-binary. And they are angry because they have to choose a male bathroom or a female bathroom, and neither bathroom works for them. So how do we think about an adolescent and their future thinking? When a teenager comes to me and says, "I will never want children," that's very different from a mature adolescent that says, "I don't want children now. I don't think I want children when I'm older, but I realize I might change my mind because I'm a teenager." When the adolescent realizes they might change their mind, they are more mature and they are more ready to make a decision. So last, what about the timing? When do we make these decisions? There's different categories related to psychiatric issues that youth experience. So many transgender adolescents are experiencing stigma because it's not culturally acceptable to be living as transgender. So there are youth that have mental health challenges secondary to stigma. Then on the right, in the light blue box, there are youth that experience challenges simply because they feel trapped in the wrong body. Gender dysphoria causes them to feel different. Then there are youth with anxiety, depression, eating disorders, just like the rest of us, that has nothing to do with being transgender. We have to think about that too. And then there are the linkage of all of them, okay? It is our job, you are all experts in the room, okay, to help understand which of this is which for each person. Each person is different, And we need to look for these relationships and help figure out what do we need to address first, and what do we need to address second, and what do we need to address third. This is a graph that just shows that many kids coming into the gender identity clinic have higher rates of mental health issues than non-transgender kids. This is from the Boston Children's Hospital Clinic, which is where I started my career. I want to take just a quick moment about the family. I don't understand how the family in Vietnam is different than the family in the United States. In the United States, different cultures, different races, different religions. So every single family that comes into my office is very different. So I try to not think about my family. I try to think about what is your family like, okay? Who's in charge? Who's not in charge? What role does respect for the parents play when it comes to the adolescent? And I think it's important to help parents understand that it's okay for them to be experiencing loss. Some parents feel this, okay? If we tell the parents, no, you're not allowed to feel that, then the parent does not want to come back to the doctor, and that does not help. So we need to help understand what is the parent going through. And in fact, help the parent understand in their own way that respecting their youth is actually respecting them as a parent. It helps them be a better parent, to be accepting of their kid in a way that only you can understand how to do that in your own culture. So, one last thing. Are we going through? The computer reboot. Oh, no, one back. There we go. I do want to mention autism and gender because this is really important. Autism and gender is something that we see more and more. Not all transgender kids have autism, but many kids come in with both autism and gender. And what's interesting is they can be very difficult because for autism, one of the main challenges is difficulty with transition. And to help a transgender person, they need to transition. How do you deal with that? And so I think that helping sometimes working with our autism expert colleagues, educating them on transgender issues is important so that we can help people with autism and with gender issues understand what is going on for that person. So to summarize, this is very complex. There's a lot of things on both sides of the spectrum. How well, on one hand, how well does the adolescent know themselves? We call that identity consolidation. Versus on the other, how much do they confuse identity and gender role? Okay, some adolescents understand this better than others. On one hand, what is the benefit of the medical intervention versus the risk of the medical intervention? On the other hand, what are the benefit of no medical intervention versus the risk of no medical intervention? Sometimes doing nothing is harmful, so we need to understand that. On one hand, we have to think about the timing of the medical intervention. On the other, how stable is the person psychiatrically, mental health-wise? And on one hand, we think about the patient struggle, and on the other hand, we have to think about the family. So I just simply want to end with this slide because I think this slide really helps bring everything together, okay? Because in order to help transgender youth, if you think about this as my perspective is correct, you're not thinking about it in total. The real truth is somewhere in the middle. Thank you.
Vâng, xin cảm ơn bác sĩ Scott với ý kiến với chia sẻ về kiến thức cơ bản về chăm sóc sức khỏe tâm thần cho trẻ vị thành niên chuyển đổi giới tính ạ.
Thank you, Gail, for that very nice introduction, and thank you all for inviting us to meet with you and learn together. It's really a wonderful opportunity and an honor and a pleasure for me to be here. I'll try to speak slowly. We'll be changing gears a little bit and speaking now about surgery very much from a technical perspective. And what I think it would like to emphasize is really the multi and interdisciplinary nature of care. So throughout the talk today, that will really be the theme running through the slides. So, and can everyone, well, we can hear okay? Yeah, great. So, we've heard quite a bit from experts regarding gender dysphoria. And from the surgical and medical perspective, and from a surgeon's perspective and from a professional's perspective, we know that adjusting the mind to the body is not one. And our role, certainly as plastic surgeons, is to adjust the body to the mind to provide congruence between the mind and the body. And we'll discuss a variety of procedures today from both head, chest, breast, and genitalia. Now, historically and traditionally, from a surgical perspective, we've been very focused on the genitalia. Much of the early work, certainly in the standards of care, in terms of surgery, really references surgery on the genitalia. That's important. We'll speak significantly and in depth about that. But I also want to make you aware of really the emerging importance of facial surgery, most specifically facial feminization surgery, as its role in facilitating social transition for those individuals who choose to do so. We'll cover quite a bit of material today, so if we don't get through everything or if there's additional questions, please stop me. And as I said, we'll go through face, chest, breast, and genitalia. I won't go through each of the requirements for all of the procedures. That can be read quite easily in the standards of care. And of note, in the revision to the standards of care 8, or the next revision, which we hope to have out within the next year or so, there will be substantive changes to surgery and access to surgery. It's important to recognize that these standards of care are not designed to be a barrier for care. They're designed to be flexible, and they're really designed to aid both professionals, patients, individuals in providing the best possible care for that individual person. We've heard about the DSM. I won't go through that, but do want to emphasize the multidisciplinary nature of care. And the multidisciplinary nature of care has evolved beyond simply physicians, simply surgeons, primary care physicians, mental health professionals. In the United States, perhaps because of some of the complexities around our healthcare system and insurance, that also incorporates administrative individuals, probably much so like in Vietnam, in terms of important things like who pays for various surgery, how much resources, financial, or in terms of beds, can we allocate to these various procedures, because we're always making choices between who pays for what type of procedure, and physical therapists, occupational therapists, etc. So as we've heard very eloquently from Drs. Aronsaff and Leibowitz, we rely heavily as surgeons on mental health professionals. Most often, we are seeing individuals upon whom we are not making the diagnosis. We rely on our colleagues, our mental health professionals, to make the diagnosis, and we're operating on a condition, really rather unique, a condition in which we're not making that diagnosis. Now, when we talk about the standards of care 7 and who's a candidate for surgery, I do want to emphasize that the slides today are going to change probably quite significantly within the next year. We've discussed child and adolescent, and while there's no surgical intervention in childhood, there are surgical interventions in adolescence. It is very common in the States, Europe, North America, to operate on individuals, certainly for mastectomy, for trans men, under the age of 18. The youngest individuals I've operated on are at the age of 14 for mastectomy. For genital surgery, I've performed vaginoplasties on individuals at the age of 17. Some surgeons in the States a bit younger than that, at the age of 16. And for procedures such as phalloplasty, I've also operated on individuals who are 17 years of age. So please recognize that some of the slides that you see today reflect the standards of care 7, which are still in effect, but we anticipate changes coming up. I'm going to skip through some of these issues because I don't think they're necessarily pertinent to our discussion today. One of the challenges that we have in the United States, perhaps worldwide though, is obesity. There's a growing problem in the U.S. For some of the procedures, we have limits on body mass index, others we don't. So for chest surgery, mastectomy, I personally, and most of my surgical colleagues, do not have limitations on body mass index. However, for genitalia surgery, vaginoplasty, and certainly phalloplasty, most of us do have some limitation on body mass index. Smoking is another area of concern, and to a degree this depends on the type of surgery. Personally, and most of our colleagues in the U.S. don't perform vaginoplasty or phalloplasty on individuals who smoke. That may be a little bit different for mastectomy and other surgeries. This is sort of just a list of the various procedures in which we perform, indicating both genital, face, and breast surgery, and we'll cover each of these today. So our goal is certainly a successful cosmetic and functional result, but that's only one part of the overall therapeutic process. I can't overestimate enough the importance of working in a collaborative and collegial fashion with our mental health professionals and our primary care professionals. Dr. Leibowitz mentioned the connection between mind and body, and I'll add mind, body, and society, because as you've heard, the influence or the impact of society plays an important role ultimately, I think, on surgical satisfaction and ultimately on surgical outcomes. As we look historically, and I think it's important to understand the role of surgery historically, surgery on the genitalia has occurred for millennia. Certainly with ritual circumcision for several thousand years, but also eunuchs of various forms of castration with removal of testicles, penis, etc., and even through modern times in Western cultures, some form of surgical alteration of the genitalia has existed and continues to exist. This is cross-cultural, it's multicultural, and it's historical. This is not a new phenomenon. Perhaps more important in the U.S., this slide simply shows the first patient to have undergone genital surgery paid for by the U.S. government. This did not occur until 2014, so just about 5.5 years ago. So until that time, in the United States government had a ban on paying for gender-related surgeries. Now, in the U.S., this ban was removed, but doesn't offer across-the-board blanket coverage for these procedures. These procedures are approved on an individual basis, on a case-by-case basis. But I would like to remind people, as we consider, regardless of what country we practice on, and recognizing that whether it's a national health system, a government system, a private insurance system, we look very, issues related to payment are not unique to gender. In the United States, for example, not until 1998 was breast reconstruction covered by many of our insurance carriers. Prior to that, breast reconstruction was considered a cosmetic operation. And if you can believe it, even later than that, surgery, for example, on cleft lip was often considered cosmetic by many U.S. insurance carriers. We'll now get into more of the technical components, and I believe we're all medical individuals, but some of the slides, of course, are going to be graphic. This is done, obviously, from a teaching perspective, not in a pejorative sense. But it's important to understand embryology in order to understand the surgical procedures which we're performing. For vaginoplasty, we are essentially deconstructing the phallus to form the relevant anatomy, recognizing that the external genitalia have homologous parts. So the glans penis is analogous to the clitoris, the scrotum analogous to the labia majora, the urethra in a sign male at birth is fused and longer than the urethra in a sign female at birth, recognizing it's shorter and forms portions, for example, of the labia minora and vestibulum, the tissue between the clitoris and the urethra. It's also important to understand normal development when we speak about these surgeries, because we have to understand what we're trying to create. So the average erect male phallus is about between about 5.1 to 5.7 centimeters, so inches, so just under about 15 centimeters. Very relevant, not only when we're performing a vaginoplasty or phalloplasty, but understanding the influence of pubertal blockers on future surgeries. So as we've heard, if we delay or pause puberty, and therefore delay development of the external genitalia, we're influencing potential future surgical procedures, and we'll discuss that a bit. Now, many of the techniques we have grown out of our understanding of congenital deformities, traumatic deformities, oncologic deformities. This is an individual who was sent to us with what was thought to be Sawyer syndrome or gonadal dysgenesis. Probably had perineal hypospadias and cryptorchidism. Has a functional phallus in the sense that he is able to urinate or micturate, able to achieve an erection, but does not have a phallus of sufficient dimension to engage in penetrative intercourse. So here, for this congenital deformity, a traditional radial forearm phalloplasty, ultimately with erectile penile implant and testicular prostheses to allow him to perform penetrative intercourse. I'll skip or I'll mention very briefly just the hormones. Most individuals whom we see for surgery for vaginoplasty will be on some form of hormonal testosterone blocker. In the United States, that's spironolactone, recognizing that there may be other preparations elsewhere in the world, and then some form of feminizing hormones, estrogen, progesterone, some form of combination with that. Now, there are benefits to early access to hormones. This is Miss Universe Canada. I don't think any of us in the room would recognize she was assigned male at birth. So for many individuals, early access to hormones, as we've heard from Dr. Leibowitz, Dr. Ahrensap and the right individuals is quite important. And similarly, pubertal blockade for this young trans man is important in the sense that we can perform a mastectomy through very minimal incisions, just incisions in a peri-areolar fashion, with leaving essentially no disfiguring scars. And he's able to walk on the beach really with no stigmata of having been assigned female at birth. So now let's go through the various surgical procedures more in depth. We'll talk specifically about the vagina, but I want to mention also the mons pubis. A colleague of mine had done some cadaver studies on the aesthetics of the mons, not pertaining as much to gender, more related to individuals who had massive weight loss following weight loss surgery. And you can read the article for the various specific measurements, but essentially it's an equilateral triangle. The mons pubis shapes this equilateral triangle. The mons referring to fatty tissue of the pubic bone that divides to form the labia majora. Now, by far and away, our surgical decision-making in vaginoplasty involves the use of the penile inversion vaginoplasty. I'll mention the use of colon and peritoneum a bit in our practice at our center. Colon is typically performed for revision vaginoplasty, so individuals who have had some form of complication, whether significant stenosis, not amenable to skin grafts, or persistent or problematic rectovaginal fistula. Peritoneum we use typically, though, for an apical cap, so for individuals who may have insufficient skin for a full inversion vaginoplasty, where we use portions of the peritoneal lining to form the most proximal 3 to 4, perhaps 5 centimeters of vagina. Now, some issues that may be a bit in flux or controversial. At our center, we continue to hold feminizing hormones 2 weeks before surgery. I'll discuss our protocol for venous thromboembolism. That's changed a bit. We no longer, in the far majority of cases, use chemoprophylaxis. We ambulate patients post-operative day 1. Everyone receives mechanical prophylaxis with sequential compression devices. Everyone is bowel prepped, and we do encourage hair removal in the genital area prior to surgery, whether that's electrolysis or laser. There are any number of different ways that flaps and grafts can be designed, and we'll walk through the most common ways to do that. But almost always, some form of skin graft is required to augment vaginal depth. That's typically a graft from the scrotum or perineum. Now, in the United States, almost all of my patients are circumcised, so we have a bit less tissue with which to form the prepuce or the clitoral hood. Not uncommon to augment vaginal depth with additional skin grafts from the flank areas. So as we think anatomically or embryologically, again, the penile skin forms portions of the labia minora and vaginal lining. The glans penis forms clitoris. The urethra is shortened and spatulated to form the new urethral meatus as well as vestibulum. The scrotum, the outer scrotum, forms the labia majora, and then additional skin grafts are used to augment the vaginal depth. Now, the vagina is dissected in a plane between the urogenital triangle above and the anal triangle below. To do that, we release the central tendon of the perineum. The central tendon of the perineum is the confluence of the superficial muscles, the lobal spongiosus, ischiocavernosus, transverse perineal muscles, with the external anal sphincter. And it's in the dissection of the vaginal canal where much of the risk and morbidity of the operation occurs. Now, this is one area, although I would say there are many different ways to perform the vaginoplasty, although we all have, I think, quite similar principles in doing it. This is one area where I do feel strongly as to how the dissection of the vaginal canal is performed. the prostate's not removed, it's typically quite shrunk because of hormonal therapy, and we can get into things like prostate surveillance, and we have our colleague Maurice Garcia, renowned urologist, who can also help with many of these discussions today. Now, I think it is our preference to construct the vaginal canal above the non-VA's fascia, so on the prostate side of the non-VA's fascia. I think in order to do that appropriately, the surgeon has to see the non-VA's fascia, incise the non-VA's fascia, and release it. I don't think it's sufficient to try to perform this dissection bluntly without releasing the non-VA's fascia. And this is where the risk of injury to the rectum occurs. Because if you are on the rectal side of the non-VA's fascia, there is really no anatomic layer between the rectum and the neo, the new vaginal cavity. In terms of the glands, the construction of the clitoris, that's the dorsal portion of the glans penis, constructed preserving the dorsal neurovascular bundle. It's my preference to dissect that with Buck's fascia, although other surgeons will also incise the tunica albuginea and elevate that additional fascial layer to perhaps protect that dorsal neurovascular bundle. In individuals who are quite thin, adding that extra layer can be a bit bulky. Now, in my practice, I used to preserve a stump of the corporal bodies on which to place the new clitoris. I no longer do that. I resect the corporal bodies completely. Maurice and I may do that a little differently, and I think there's no real consistency. That's one area where there's surgical variability and a variety of reasons why one surgeon or another may choose to do so, and we can certainly have those discussions offline. I have a few videos, if we're able to play those videos. Okay, great. This is elevation of the skin graft from the scrotum. This is passed off to an assistant who can then defat this graft, remove some extra follicles, and suture this over a dilator, as you see here. We then expose the corporal bodies, the corpus spongiosum, and elevate the skin off of the penile shaft here. And with this, deconstruct the penis into the various component parts. Okay. Now, this is the important part of the dissection. Are we able to go back for 1 second on the slide? We can advance one more. And one more. Keep going. We can go forward. I think we're going backward instead of, yeah. Yeah, go. And one more. Yeah, this is the important part, using the Loseley retractor to expose and mobilize the prostate. And it's at this point here where we can directly incise the non-VA's fascia. After incising the non-VA's fascia, we're then able to perform blunt dissection to create the vaginal cavity. This is the incision along the non-VA's fascia, a true fascia layer, something I don't think that can be done safely if done only bluntly and blindly. Once we incise this, this plane will open up, and then we can construct the vaginal cavity. Elevation of the neurovascular bundle by incising Buck's fascia. This is buccal fascia that's being lifted, sparing the tunica albuginea, lifting the fascia off of the corporal bodies, and dissecting the glans penis and the various component parts. Separating the spongiosal tissue from the cavernous bodies, and then now completely resecting the cavernous bodies along their attachment to the ischium. Okay, we can go back and going backward. Okay, we can keep. Yep, we keep going. Forward, yeah. Oh, and then following, of course, following the surgery here. So I'm going to catch up. Yeah. Okay. Great. Okay, so our algorithm is to hold hormones 2 weeks before surgery. If someone has a history of a prior thrombotic event, they have a hematology consult. We do perform a bowel prep the day prior to surgery in the event that there is an injury to the rectum. We use unfractionated heparin on induction of anesthesia. Mechanical compression postoperatively. We pack the vagina and leave the packing in place for approximately 5 to 6 days, and we ambulate the patient the first day following surgery. We typically remove the packing about 5 to 6 days after surgery. The catheter, Foley catheter, is removed about 6 to 7 days following surgery, and dilation starts about 10 to 14 days following surgery. I used to start dilation earlier. However, I think there's a reasonably high incidence of wound breakdown, certainly along the posterior fourchette, and I think having a few extra days of healing prior to vaginal dilation has been helpful in minimizing some of those issues. Now, vaginal dilation is critical following surgery. In the States, we've recently, over the last couple of years, begun incorporating pelvic physical therapists to assist with that. Pelvic physical therapy can be quite helpful. Many individuals before surgery may have pelvic muscle dysfunction for a variety of reasons. In addition, they may have preoperative sexual dysfunction. They may be not sexually active. They may be anorgasmic. And physical therapists, I think, pelvic physical therapists can be helpful with both pre-op and post-op recovery in terms of sexual functioning and helping the individual to be comfortable and confident when inserting a dilator. So complications can and do occur, and the rate and incidence of complications is not necessarily low. In fact, wound healing complications, probably on the order of 15% or so not infrequent. Most of those are managed by local wound care as an outpatient. However, on occasion, individuals may have to return to the operating room. Now, let me change a bit for a moment to intestinal vaginoplasty, so what happens after a failed primary procedure. And in our hands, this is typically treated most often either with intestine, typically using colon, typically left colon, on occasion right colon, rarely ileum. Is that time or not? No? Okay. So when doing revision vaginoplasty, I typically work in a two-team approach, both from an abdominal and perineal approach. I think that's helpful to facilitate dissection and minimize the risk of injury to adjacent structures, specifically the rectum or urethra. Now I'm going to go through just a bit because this is less common and I want to get to our other, some of our other procedures. So as you can see here, the rates of complication are not necessarily low. However, patient satisfaction remains quite high. I'm going to shift now into some breast and chest procedures, and there are a variety of differences anatomically between the physical features of assigned male or assigned female chest at birth. So for the assigned male or the cisgender male, the pectoralis muscle is typically thicker, the chest wall is wider, there's less skin, so a tighter skin envelope as compared to cisgender women. And that can create certain challenges when performing, for example, breast augmentation. There are perhaps some advantages to hormone therapy in terms of softening the skin, allowing some breast growth, and stretching the skin preoperatively when performing augmentation mammoplasty. And again, there are anatomic differences in the body between a traditional android body habitus and gynoid body habitus in terms of fat distribution, and perhaps how hormones influence fat distribution. And as you can see on this side of the screen, a post-operative individual after breast augmentation, vaginoplasty, and some body contour, as well as hormone therapy and body contouring to achieve a more gynoid body habitus. In terms of breast surveillance, we have the same criteria as we do for cisgender women based on age, personal history, as well as family history in terms of screening criteria for things like mammography. Surgically, there are some additional maneuvers that we perform because of the anatomic differences. So, for example, release of the pectoralis major muscle along the sternal border, lowering of the inframemory crease, typically choosing larger implants because of the differences in chest wall, and not uncommon to combine both breast augmentation and vaginoplasty. So now let me speak just briefly about facial surgery. There are different types of facial surgery. For feminization surgery, most of that pertaining to gender surgery involves skeletal manipulation. Many of the soft tissue procedures, facelift, eyelid surgery, blepharoplasty, etc., are more done for rejuvenation or aging procedures, unless done in combination with skeletal surgery. So when we perform osteotomies of the face and shorten or change the facial skeleton, we may need to reposition the soft tissue as well to prevent sagging and drooping. There are any number of differences between the stereotypical male and female faces. Females typically have a shorter, rounder face with a convex forehead, a lateral arch to their brow, with the eyebrow positioned above the level of the supraorbital rim, the absence of typical male pattern baldness, the Adam's apple or thyroid cartilage. So the surgical manipulation typically involves the frontal bone, the glabella, the mandible, chin, and mandibular angles. Most of the mid-face work, with the exception of the nose, is now handled with some form of fillers, whether lipofilling or hyaluronic acid. We break the face down into upper, mid, and lower thirds based upon each individual's goals or their anatomic appearance. Most often for the upper third of the face, an osteotomy of the frontal bone and frontal sinus is required to set back the frontal bone. Rarely is surgically burring the frontal bone enough to treat that forehead. We do obtain CT scans prior to surgery, and the procedure is designed based on the thickness of the anterior table, the anterior wall of the frontal sinus, in relation to the degree of bossing. Typically, the frontal bone is too thin to simply burr in order to achieve a more flat or convex appearance to the forehead. So through a coronal incision or with an osteotomy, the frontal bone is removed, the frontal bone is recessed, and then we do use internal fixation, most often with plates and screws in order to do that. Other manipulations, soft tissue involve shortening and filling of the upper lip. The stereotypical female upper lip is shorter and fuller than the stereotypical male upper lip. Most of the upper lip augmentation is done now either with hyaluronic acid or lipofilling, and then reduction of the Adam's apple, referred to as a tracheal shave or reduction thyroid chondroplasty, where the Adam's apple is reduced. Now, the potential morbidity of this operation is an injury to the attachment of the vocal cord. And if the vocal cord attachment is injured, this is very difficult, if not almost impossible to correct. So we asked our anesthesia colleagues during surgery to insert a fiber optic scope, which you can see here. We're then able to pass a needle to identify the position of the anterior commissure, the vocal cords, and then remove cartilage, leaving about 2 millimeters of support to the attachment of the vocal cords. How much time would we have? A little bit more time? 5 minutes? Okay. So that 5 minutes is going to leave us with the most complex procedures of phalloplasty and metoidioplasty. Most often, so I'm going to run through some of these quite quickly. Mastectomy, still the most common transmasculine procedure. Most often in the States, most common procedure is what's referred to as the double incision mastectomy because it's performed through 2 incisions, most often with a free nipple graft, so the nipple and areola are detached, made smaller, and repositioned. Unlike the mastectomy for cancer surgery, oncologic, we preserve the pectoralis and serratus fascia so that there is a nice gliding plane over the chest wall skin and doesn't appear skeletonized. Not uncommon to incorporate liposuction as well for additional contouring of the chest. So again, double incision with free nipple areola grafts, and the advantages of pubertal suppression. So shorter incisions for individuals who have less tissue. So for those individuals who have been put on pubertal suppression, we can perform less deforming, surgery with less visible scars, and leave the individuals with really very little, if any, stigmata of having a previous surgical procedure. So the tissue is removed simply through a small incision in the areola from the 3 to 9 o'clock position. Now, in terms of what we call bottom surgery or phalloplasty and metoidioplasty, metoidioplasty refers to lengthening of the hormonally hypertrophied or virilized clitoris, most often done with lengthening of the urethra. The metoidioplasty may be converted most often to a phalloplasty at a later date if an individual so chooses. For some individual, metoidioplasty may be the procedure of choice. Really, the difference is that metoidioplasty constructs a phallus with more of a micropenis, so a penis that is functional in terms of micturition, urination while standing, most often not capable of penetrative intercourse, although there are reports of individuals being able to perform penetrative intercourse following metoidioplasty. And again, important to understand the individual's goals and expectations prior to designing the procedure. The radial form remains still probably the most common procedure for phalloplasty, seconded by the anterior lateral thigh, and there are various other combinations of groin flaps, abdominal base flaps, etc., etc. These are procedures, though, that we do rely on hormonal hypertrophy, so I would argue that here taking hormones for at least a year, if not 2 years, to allow sufficient growth of the clitoris is important in terms of optimizing post-operative surgical results. And you can see the virilization achieved with preoperative hormones. And in order to be able to have a successful urethral lengthening, meaning the individual can have the phallus pass through an open zipper, stand to urinate in a public restroom, we need to have perhaps 9 to 12 centimeters or so of augmentation of the clitoris. In individuals who are obese, for example, we're really constructing more of a buried phallus, and although they're able to urinate while standing, they may not be able to use a public restroom because the micropenis, the phallus, will not exit their zipper. much of the early literature on metoidioplasty in terms of outcomes out of our European colleagues, I think, has much higher rates of complications than we experience. I think because they try to do everything in a single stage. So, for example, placement of testicular prostheses, et cetera, rather long lengths of stay in the hospital and so on. I don't think this is consistent with the most recent data. I would argue that the rates of complications, whether healing or urethra infection, are actually substantially lower than that. Our preferred technique uses a variety of local tissue, labia minora, in order to lengthen the urethra. Typically a layered construction of the urethra with the flaps of the labia minora augmented with buccal mucosa. So the two important maneuver, or certainly the one important maneuver, is release of the ventral chordae to allow advancement and straightening of the urethra that then creates a bare spot over the corporal bodies. This bare spot can be reconstructed with buccal mucosa or various labia minora flaps depending on the particular procedure of choice. The dorsal neurovascular bundle is not altered, so sensation to the glands is maintained. And here you can see the advancement achieved simply by releasing the ventral chordae, so very much analogous to a severe perineal hypospadias. Elevation of the skin off of the hypertrophy clitoris, and then reconstruction of the urethra augmented with buccal mucosa. We performed secondary scrotoplasty, so approximately 3 months later, the scrotum is constructed by retro-displacing the labia majora, and at the same time then placing the testicular implants. I think that achieves a more anatomically correct position of the labia majora than trying to place the implants at the initial procedure. Also in the States, perhaps because of the obesity, we often combine this with some form of Mons lift or Mons resection. So in our vaginoplasty patients, we're constructing the Mons. For many of our metoidioplasty or phalloplasty patients, we're deconstructing the Mons. So removing, lifting the fatty tissue over the pubic bone, typically through the incisions that you see here. Now, in terms of phalloplasty, as I said, the most common procedure remains the radioforum flap. I think that's still the procedure by which we measure most of our outcomes. It allows us most often to do the most work in a single stage with the best sensory outcome of the patient. I think the ALT is a reasonable alternative in terms of sensation, probably second only to the forearm. We don't do the latissimus dorsi. I don't think that's an optimal choice for phalloplasty. That's personal preference. It's an insensate flap. Typically a phallus tube that is anatomically oftentimes not accurate. In our practice, most individuals choose to have what's referred to as a glandsplasty or circumcised appearance, although not always, as you can see from the middle picture. Phalloplasty is certainly the most complex and technically demanding procedure with a high rate of complications, most specifically in the urethra, whether stricture, fistula, or some combination thereof, with reports as high as 80%. I would argue that complications are closer to 100%. Not all necessarily require surgical intervention, but some form of postoperative complication, whether urinary tract infection, delayed healing, or what have you, occurs quite commonly. Now, I'm being asked to shut down, so I'm going to finish up just by saying that 9 to 12 months later, once the individual is able to successfully avoid, choice of implantable prostheses, if desired, can be placed, whether inflatable or malleable. There are a whole set of other issues concerning that. So I'm going to leave it. I'll give one more minute just to show quite briefly technically how we do it. Typically, there's a neurorrhaphy between either the donor nerves in the form of the thigh and the ilioinguinal nerve. The scrotum is constructed from the labia majora. The double tube technique you see here with the urethra forming the phallus form with a tube within a tube, one tube for the urethra, the second for the shaft. The various lengthening of the perineal portion of the urethra. I realize we're going quite fast here for the most complex parts. I'm glad to speak with people afterwards. and then placement of the phallus in its position with the various neurovascular anastomoses. So I'm going to leave it there because I've been told to shut down, and I'd be glad to speak with anyone at lunch.
Vâng, xin cảm ơn bác sĩ Ryan Center với bài chia sẻ kiến thức nền tảng về phẫu thuật. Vâng, kính thưa các anh chị, sau đây chúng ta sẽ có thời gian thảo luận để giải đáp các thắc mắc, các câu hỏi của các anh chị về các bài trình bày ngày hôm nay ạ. Ban tổ chức xin lưu ý là các anh chị đặt các câu hỏi trực tiếp tại tập huấn thì chúng ta sẽ ưu tiên các câu hỏi về các nội dung các chuyên gia đã trình bày và chia sẻ ngày hôm nay. Còn các câu hỏi liên quan đến các nội dung khác thì ban tổ chức xin phép sẽ ghi lại câu hỏi của các anh chị và để gửi lại cho các chuyên gia.
So we have Brad and Dr. Lin that are going to, if people want to ask questions, I would request that one person answer the question, and so we can get through many questions. I think that we did really well yesterday. We got many questions answered. And so, now I know yesterday there were 2 people that had child and adolescent questions. Can you put your hand up if you were like those people yesterday? I don't remember. We had the child and adolescent questions. Oh, stay here.
Em xin chào các chuyên gia. Ngày hôm qua thì em có đưa 2 câu hỏi liên quan đến vấn đề về sức khỏe trẻ vị thành niên chuyển đổi giới tính ạ. Thì câu hỏi thứ nhất là trong tình huống ở Việt Nam thì khi mà có một số cha mẹ đưa trẻ đến bệnh viện khám và họ có yêu cầu rằng là tôi có nên cho con tôi làm các cái xét nghiệm liên quan đến để xác định rõ về giới tính, xác định rõ về gen hay không ạ? Thì đối với các kinh nghiệm của các chuyên gia thì các chuyên gia có thể cho ý kiến về vấn đề này được hay không ạ? Câu hỏi thứ hai là trong trường hợp mà đối với các phụ huynh khi mà họ có con, đặc biệt là ở lứa tuổi vị thành niên sớm á, thì người ta rất là cảm thấy khủng hoảng khi mà con của họ có vấn đề về giới tính, và người ta trong cái trường hợp đấy thì mình nên làm việc như thế nào đối với các gia đình, nên tư vấn với họ ra sao, và có thể là những họ không thể chấp nhận được thì trong cái trường hợp đấy mình nên giải quyết như thế nào. Xin cảm ơn.
How's this?
Yes.
Working?
Yes?
Yeah. Okay. I will begin again. I'm going to answer the second question first about families and parents. And we'll be talking about this a lot tomorrow as well. But think of this. Think of a spectrum of family acceptance. So you start where the parent is, or the family, and hear their concerns and their confusion, and give them a chance to really express that and make a connection. And then at some point, what I do in my country as a mental health professional, in which we have many families who are just like that and confused, I tell them that I feel it's my obligation as a professional to provide them with some other information on what I know for the stresses of youth who are exploring their gender when they don't support. And I work with the idea of cognitive dissonance, that parents love their children and they want to protect them, and have the best for them. They may also have very negative attitudes towards transgender people. And I like to operate from the assumption that love conquers all. So that the love for the child will overcome transphobic ideas. And that is a process over time, and developing a trusting relationship with the family first. And in that context, I can answer the first question. There is no DNA test or litmus test to identify a child's gender. And it would only create distress for a child to be put through such a procedure.
Thank you.
Did that answer your question?
Yeah. Over here. Brad's coming your way. Yeah.
Oh, Brad.
Oh, okay.
Vâng, cảm ơn các chuyên gia. Tôi có một số các cái chia sẻ và có một muốn hỏi như thế này, bởi vì từ hôm qua đến hôm nay thì tôi có một cái rất là mới và hiện nay ở Việt Nam chưa có, đấy là về cái thuốc ức chế dậy thì với mục đích để cho những bệnh nhân chuyển giới mà còn rất là trẻ, và sau khi các cái bệnh nhân đấy, ví dụ những cái trẻ là nam mà họ định hình sau này họ muốn là con gái chẳng hạn, thế thì khi dùng cái thuốc ức chế dậy thì đấy xong á, thì mục đích của người ta là người ta muốn bỏ qua cái giai đoạn dậy thì của cái nam đấy. Thế thì sau đó người ta chuyển sang một cái hình thức nữa là sử dụng nội tiết là giai đoạn 2. Thế thì sau đó thì họ vẫn phải chuyển qua giai đoạn 3 là phẫu thuật chuyển giới. Thế thì nó sẽ có sự khác biệt giữa cái đối tượng này với cái đối tượng mà sau khi họ đã trải qua cái độ dậy thì rồi. Thế thì nó có một cái ưu điểm là gì? Là ví dụ những cái trẻ nam đấy khi chuyển qua giai đoạn estrogen thì người ta sẽ không mất công ở cái phần ngực và cái phần hàm mặt và cái phần khung xương, bởi vì nó sẽ biến, nó dưới tác dụng của cái thành phần nữ đấy thì nó sẽ làm cho cái hình dáng của cái người nam đấy nó có xu hướng giống với nữ giới rồi. Nó khác với những cái đối tượng mà đã trải qua cái độ tuổi dậy thì nó đã bị một cái quãng thời gian ảnh hưởng của cái nội tiết, cho nên là người ta phải can thiệp nhiều hơn. Thế thì tôi muốn hỏi một cái là khi mà ức chế như thế thì cái bộ phận sinh dục của nam là nó bị teo đi rồi, đúng không ạ? Thế thì nó có một cái khác biệt nữa là nó sẽ khó khăn hơn trong cái giai đoạn phẫu thuật chuyển giới giữa đối tượng đã sử dụng thuốc ức chế dậy thì với đối tượng mà ví dụ 18 đôi mươi người ta mới can thiệp, đúng không ạ? Và nó có một cái khác nữa là ở những trẻ đấy thì sau này cái cơ hội làm bố làm mẹ của họ không còn, bởi vì làm gì có trứng với tinh trùng đâu. Thế còn đâu những cái đối tượng kia thì họ nếu mà sau này muốn có con của họ thì họ vẫn có thể là dự trữ trứng hoặc là dự trữ tinh trùng và bằng hình thức có con, bằng hình thức mang thai hộ. Thì tôi muốn hỏi các bác sĩ phẫu thuật đấy là nó có sự khó khăn gì? Đấy là câu thứ nhất. Câu thứ hai đấy là đã có một cái khảo sát gì đánh giá về độ hài lòng của những bệnh nhân sau chuyển giới? Bởi vì chuyển xong thì tôi muốn quan tâm đến cái người ta gọi là cái khả năng tình dục của họ. Họ có hài lòng hay không? Tất nhiên về những cái khác có thể họ sẽ hài lòng, họ sẽ thấy giống một người nữ hơn. Nhưng cái khả năng tình dục là khi mà anh chuyển thành nam ấy, cái dương vật của anh hoạt động được không? Anh đi đái có vấn đề gì không? Bạn tình của anh có cảm thấy sung sướng với vấn đề đấy không? Ở nữ, cái âm đạo của họ có đủ rộng, đủ dài để họ quan hệ với nam hay không? Hay là lại biến chứng và họ lại sầu muộn về cái vấn đề đấy? Và khi có can thiệp, ví dụ như là nếu họ bị hẹp, họ bị dò trực tràng âm đạo, họ bị có những rối loạn về mặt tiểu tiện, hoặc họ cảm thấy khô rát khi quan hệ với bạn tình, thì có những cái xử trí gì? Tôi xin hết.
Sorry, with all due respect, there's so many good questions there. It might be helpful if we stopped for a moment and try to answer some of them, because I'm already forgetting the first ones. So, and we all want to answer all of your questions. So, if I can remember, the first question was, are there any bad effects of hormones, puberty-blocking hormones, for surgery? And my experience is for the trans women, so sex-assigned birth, male, but who identify as women, one of the drawbacks that some of us have, the surgeons, we're surgeons, have observed is that if they don't go through puberty, they have, some people, not everybody, some can have very small penises when they get older. And as Dr. Schechter explained, we use some of the penis skin, to make the vagina. So if it's very small, we have less skin. And then we have to get skin from somewhere else. The scrotum, that may be very small too, or somewhere else. So that's one of the drawbacks. I don't think for trans men or trans masculine people, it is so much of an issue. What do you think, Dr. Schechter?
Thank you, Maurice, and thank you for the question. Like anything, I think there are advantages and potential disadvantages for blockers and hormones. Dr. Garcia has listed some of the concerns for women interested in vaginoplasty. I think the advantage for trans men, trans boys, certainly in terms of breast or chest surgery, is the increased chance, increased likelihood that we can perform mastectomy through shorter incisions, smaller incisions, shorter scars. I think with perhaps less disfiguring operations. You got into some questions regarding fertility and so on. I'll leave that. That's not my particular area of expertise. I'll let Maurice, probably Dr. Rosenthal, Dr. Ettner, et cetera, who are endocrinology, urology, primary care, speak a bit more about that. Looking down the road as far as things like ultimate satisfaction and so on, now speaking specifically for adolescents who've undergone, I don't think, and you're asking about data, I don't believe we have that data. So what happens 10, 15, 20 years from now? I think it's a great question, one that we struggle with as surgeons, especially recognizing that for individuals who may not be sexually active, may be uncertain in terms of their fertility, may not have explored their sexuality and so on, it's difficult when performing these irreversible operations on genitalia that will affect function, sexual satisfaction, reproduction. Where that all sorts out 10, 15, 20 years from now, we don't have a data-driven answer to my knowledge. Maybe Dr. Leibowitz or Dr. Ahrensaf can expand on that.
You see how many questions that you asked. They're about surgery. They are about fertility. They are about mental health. Let's take a step back. This is why we need a team. This is why we need the surgeon, why we need the endocrinologist, why we need the primary care doctor, why we need the psychologist, the psychiatrist, to all put our perspectives together to understand for each individual the risk and the benefit, and help the family understand what we know and what we don't know, what's important for now, what's important for later. I think it's important, though, that we don't think about this as a process, the same process for everybody. Not every single person wants to have surgery. And so if we think about each person and assume that they want surgery later, then that's not helpful. If we assume they don't want surgery later, that's not helpful. We have to understand that every single human is different. And I think ultimately getting to know, being a team together with the patient, with the family, with the doctors, and putting our heads together is the best way to help make decision for each person.
Thank you, Scott.
And I wanted to add one thing, and this particularly pertains to youth, but for every individual, building on what Dr. Leibowitz just said, is that it's really important that families be fully informed. For example, around fertility, that they know when they're making decisions what the forward path is, and we often make the mistake of skipping over certain things, and that's why the team is so important, because we'll catch each other if we missed anything, but families really are the center of this. The particular person receiving the services is the very center, and then the family around them. So you ask such important questions, which every family is probably asking as well.
Thank you, Dr. Diane.
And I want to emphasize that, because for the surgeons in the audience, I'm not sure how, probably not dissimilar that in the States, the surgeon may meet with the patient once or twice for half an hour. The primary care, mental health professionals have relationships that may have existed for years. So as surgeons, when we're discussing surgery with the patient, we're very comfortable at speaking about healing and bleeding and infection and so on. But all these other issues, that's not certainly my area of expertise. And for me to try to counsel patients on complex family, social, school, interpersonal relationships, I just wouldn't be doing someone a service in that regard.
Thank you.
Vâng, trước khi có các câu hỏi tiếp theo thì ở đây sẽ có một ý kiến về các chia sẻ của chuyên gia.
Hi. I think that we do have some evidence because I think that is a very important question that the doctor said that, you know, what is the certification of the patient. Yesterday, Doctor, I'm sorry, I forgot the name, but he presented that, you know, after 6 years we have a follow-up, and we see that, you know, if you look the overall picture, you know, people well-being is improved much more. The important question here is that, you know, when I think it's we should distinguish between gender identify and the sexual need. People come to do the surgery because they want to change the gender. They don't talk specifically about sexual need. And so when we talk about sexual certification, we need to bring it broader. Maybe we think that, you know, they do the surgery to do sex, but maybe they are not. So I think it is very important question that we ask ourselves, and we think, you know, why we pay attention on the narrow focus. Yeah.
Yeah. I wanted to respond to that. I mean, I agree and also disagree. I think that some people come to, if we're talking about surgery, people come to surgery with expecting and wanting different things from it. I agree, in my experience, not everybody is dying to have surgery so they can immediately start having sex, but rather surgery is part of intimacy, even if it's not sexual intimacy, because interpersonal intimacy can always lead to sex. So my experience is that a lot of patients feel it's difficult to have relationships if they're not able to, when the time comes, to be sexual with a body that they don't like and feel bad about. But I think we have to step back and just keep an open mind that different people are going to come wanting not very different things, but sometimes some things are more important to other people than from surgery compared to others. Getting back to the last question, there was so many questions that I think could be perceived as barriers. What about fertility? What about sexual satisfaction? What about long-term this and that and the other? And I want to just say I don't think those should be perceived all as reasons to not do surgery, but rather those are things to keep asking and talking to patients about. And patients will tell us when they're ready to do surgery. Patients will tell us what their priorities are, their expectations from surgery. As many of you know, most of medicine is managing people's expectations. Am I going to die tomorrow, in a month, 10 years? Am I going to be happy, not happy? Is it going to change my life? Is it not? You know, everyone has different questions, and I think our job as doctors first is to help people have realistic expectations and always, always, always keep talking about expectations and what we can do and what we can't do and what they should still keep thinking about.
Thank you. And that talks about planning and documenting that course, because we're going to talk about it all that day, about what the expectations are and what the gender-affirming goals are. It's another way to say that.
May I add one thing? You are now going to see us work as an interdisciplinary team here, which is from a mental health point of view. Many of the youth I work with are very sexually inhibited. They have no sex, and they have no romantic relationships until they can feel more comfortable in themselves. So if you think of it even just really as a binary thing of if you have the potential to be sexual or not, that often surgery simply opens up the gates to the possibility of being a sexual person, no matter what form that sexuality takes.
Thank you. Dr. Lin.
Yeah, I just wanted to say that the young man here has a question. But before you ask a question, could you let us know whether you're a psychologist, surgeon, what your discipline is?
Okay. Tôi xin tự giới thiệu về tôi là bác sĩ Dương, công tác ở khoa tạo hình thẩm mỹ bệnh viện Trợ Rẫy. Tôi có 2 câu hỏi dành cho các chuyên gia. Câu hỏi thứ nhất tôi hỏi mấy cái bạn mà đã được xác định giới và đã có cưới như là có gia đình với nhau, nhưng bây giờ đang có 2 group có nghiên cứu, mấy bạn có nghiên cứu không, là một group là không sử dụng hormone và một group có sử dụng hormone, thì giữa 2 cái đó thì cái nào có sự khác biệt về mức độ hài lòng sống chung với nhau hay không, về lâu về dài, hay là chúng ta thấy ngang nhau? Tại bây giờ thì mấy bạn cũng có lo lắng về vấn đề sử dụng hormone lâu dài và một group thì không sử dụng. Đó là câu thứ nhất. Câu thứ hai dành cho bác sĩ Lauren là sau khi mình sử dụng cái dương vật đó thì bác sĩ đã có sử dụng silicon hay sụn sườn hay là để tạo khi mà để giúp cho cái người ta khi quan hệ tình dục, thì giữa những cái đó thì cái nào mà nó để làm cho cái sự quan hệ tình dục nó thoải mái nhất và cái hiệu quả nhất và nó không ít những biến chứng nhất, ví dụ như là sụn sườn hay là thanh silicon hay là một cái công cụ hỗ trợ khác. Xin hết.
Thank you. So if I understand correctly with metoidioplasty, the question is how are there devices to help with sexual satisfaction following surgery, or is there the need for hormone? I want to make sure I understand your question correctly. Oh, okay. Okay. Okay. So if the question was phalloplasty.
I want to ask you, sir, after you reconstruct the pieces, but you need to use a silicone or the contact to do have the pieces when they use the sexual. Do you understand?
He's asking about the erectile function.
Okay. Oh, okay. Okay. Got it. Got it. Got it. Okay. Thank you. Thank you. Thank you. So, and then I'll give it to Dr. Garcia as well as a urologist. There are some flaps, fibula, that can incorporate bone, the fibula bone. Stiffeners historically have been used, such as rib. Remember, there's Wolff's Law. So in terms of using bone, for example, if bone is not stressed, it will atrophy. So generally speaking, trying to create a stiffener with a fibula flap, for example, or rib cartilage, tends not to function well. Also, with the phalloplasty, when you are not being sexually active, you want ideally the phallus to be flaccid. Okay, so if you have a fibula bone in, that can just present some practical challenges during the course of the day if you're trying to go to the gym and exercise, and so some practical challenges. The two general types of prostheses are either inflatable or malleable. There's advantages and disadvantages to both. Some depend on patient characteristics, and none of the prostheses are designed to be used in a phalloplasty. So there are many challenges associated with placing the implantable prostheses within a phallus. There's a device that's not available in the US that is more specifically designed for a phalloplasty. Some of our European colleagues are using it. I don't believe the data has borne out well, though, for that particular device. Typically, the challenges with the prosthesis is in a phalloplasty, in a flap, are how to fix it, because we don't have the corporal bodies in which to seat or house the implant, okay? Risks of erosion, okay? Higher with the malleable prosthesis, which is rigid all the time, it's simply bent up or down. So the complication rates of the prostheses are actually quite high. We tend to favor the inflatable prostheses. Historically, we've used a three-piece prosthesis, so a reservoir placed in the preperitoneal in the abdomen, one of the hemiscrotum with the pump, and then, if possible, 2 cylinders in the phallus to provide more stability during intercourse. Issues relating to dislodgement, erosion, whether through the urethra or through the skin, can be quite problematic. So that's just another discussion in and of itself. There are external stiffeners that can be used as well. I don't recommend, some individuals will wrap their phallus with various elastic devices. I tend not to like that for obvious reasons in a flap, for a tourniquet effect and the potential for secondary flap necrosis. But I'll leave it there and turn it over to Dr. Garcia.
Thanks. I was going to say, I think part of your question, use the word satisfaction many times. So the question is, what type of satisfaction? Erection satisfaction is one issue. The other is just the ability to have an orgasm. Orgasm is clear, right? And our experience with that for trans women is that it's very good after sex. In fact, most people say it's better after surgery. I didn't mean sex. It's very good after surgery, and many people will say, most in my experience will say it's better. It's just as good physically, but it's better up here because it's orgasm with a body that they love instead of a body that they feel very negatively about here. And for trans men, as Dr. Schechter explained, what used to be the clitoris, we like to call it the small penis because it's more gender-affirming term, still has very good normal sensation. And we put it somewhere where they can feel it with masturbation or with sex. In addition, some of the phalloplasty techniques that he didn't have time to get into, we connect the nerves from the flap to one of the clitoris nerves. So then the penis can have sexual sensation from touching it. So sexual sensation is very good, and that's a great thing. Erection, in my experience, erection is very important, but not nearly as important for everybody as being able to still function for themselves sexually with orgasm.
Great, thank you.
I also think for the testosterone for trans men is quite helpful in their ability to orgasm. I think many of the trans men unlike many of the trans women, tend to be much more sexually active prior to surgery. I think in our experience for many of the trans women, their sexual, romantic interest, sexual activity prior to surgery is much more variable.
Thank you. And we have a question. Thank you.
Vâng, tôi xin được giới thiệu, tôi là Loan, làm trưởng khoa vị thành niên ở Bệnh viện Nhi Trung ương, và tôi xin có một cái câu hỏi là trong cái bài giảng của các chuyên gia thì chúng tôi thấy rằng là với những cái người chuyển giới hoặc là có những cái người mà nó không tương xứng giữa bản dạng giới với lại thể hiện giới, và trong cái bài giảng thì các chuyên gia có nói là có những người là kiên định và có những người là bất kiên định. Thế thì có thể cho chúng tôi những cái dấu hiệu nào để chúng tôi có thể hiểu rằng là cái người này có vẻ như là kiên định, còn những cái người là bất kiên định, để trong cái quá trình mà chúng tôi tư vấn hoặc là tham luận cho đối tượng vị thành niên cũng như là cho cha mẹ, chúng tôi cũng có thể có những cái định hướng để mà làm việc ạ.
I think both of us should answer.
Dạ.
I think what Dr. Ehrensaft was referring to when she was talking about persistence and the word desistance, she was talking about little kids who are before puberty, children before puberty, instead of teenagers. Okay, so I think that there's a difference between children and then there's teenagers. I'll start with the approach to everybody. You cannot predict the future. None of us have a magic ball. Okay, the goal here with children is we don't do any hormones. So we're not doing any puberty blockers, no puberty blockers, no hormones with children at all. So everything that happens before that medically, there's no real implication or no consequence, because everybody agrees that you would never do that, okay? Now, if a child socially transitions to living as a different gender, whether or not they will persist or not continue to feel that way, as long as we share with families that they need to keep an open mind about their children, it's possible that a child may ultimately, as they become an older teenager and they go through puberty, not feel like they are a different gender. That's possible. But in which case no medical issue has happened. So I think helping parents understand that their kids might evolve into any number of outcomes and that you don't know, but living with the here and the now and helping them realize the here and the now is what matters most for that child's emotional well-being is important. And then with the teenagers, it's when they are going through puberty, evidence and data from the Amsterdam clinic for the most part. The European colleagues are very ahead with the research, show that kids experiencing this gender identity incongruence once their bodies go through puberty, the debate about them continuing to feel this way into adulthood is much less of a debate. Okay, that whole debate does not really exist once kids go through puberty and feel this way for a significant amount of time. But even so, with teenagers, it's important to know that not every teenager chooses the same pathway. Not every teenager wants surgery. Not every teenager even wants a hormone blocker. Some prefer fertility, and I have a patient that actually did not want to go on to puberty blockers because she wanted to preserve her sperm for fertility and go through male puberty. I mean, we educated, and she decided this on her own, very mature for 13 years old. So it's about educating and helping people understand the decisions they need to make for themselves.
Thank you. So I'm going to go back to the younger children, and I will tell you personally that when I read all the research about per sisters and D sisters, which I was very interested in for the same reasons of your question, I scratched my head and said, this is making no sense to me. This is apples and oranges. Apples and oranges, completely separate from each other. So I evolved a notion of thinking about apples and oranges. The apples are the children who are primarily dealing with their gender identity. And the oranges are the children who are primarily dealing with their gender expressions. And when you go back into the research that's already been done, you can differentiate the two groups in the following criteria. And it's never perfect because, as was just said, every child is different. However, there are some patterns. Children who feel free enough to say the following, not I wish I was a girl, but I am a girl, are more likely telling you a story about their gender identity. Children who at a very young age are very upset about the genitals they have and ask, can I send them back? Can I trade with my sibling for a different gender? Are often more likely dealing with their gender identity. Children who simply feel more distressed when people say, for example, what a cute little girl, and they say, I am a boy, are also telling us something about their gender identity. Then we have another group of children. They're quite happy with the bodies they have. They may imagine and have fantasies about having a different body, but they like theirs too. They're not distressed about their body. And they typically will say not, I am a girl, but I wish I was a girl. And often in their play, there is a lot of what we call cross-dressing, or wearing the clothes and the appearance of the other gender as fanciful and playful and sometimes very dramatic. Where the first group will simply want the regular clothes you could go to the store and buy for a child of the gender they're trying to say they are. It's not play, it's very serious work. And the second group of children, particularly if they were designated male at birth, have historically been the children who have been targeted as quote-unquote being effeminate boys with attempts at conversion therapy. A good number of the oranges will actually grow up to be gay, lesbian, queer identified, not all, but the research shows a fair number, and that they are exploring and expressing their gender on the way to consolidating a sexual identity. And those little boys have been the ones that have been most at risk for conversion therapy. And historically, it was to stop them from being gay. Now, it's to stop them from being transgender. And international standards say this is harmful treatment. So your question is very important and about making sure that we get children in focus. And I just want to add one last thing. I realize that we cannot stop at oranges, apples and oranges. We also have fruit salads. And the fruit salads mix up both gender identity and gender expressions. And in our country, that's a growing group of children, youth, and adults who identify as non-binary. And they're saying it's both in their expressions and their identity. And these are our challenges now. For example, when a youth comes in as an adolescent and says, I like my genitals just the way they are, but I just don't want breasts, and thank you no to hormones, because this is the gender, what I call the gender mosaic I want to put together for myself. There's no DNA test, there is no litmus test, but it is really exploring each person to find out their gender narrative and to be able to give them a gender health plan.
Thank you.
Can I just say one thing? I know.
How quick is it? Is it
very
really
quick, very quick. There's also seeds where you don't know if they're an apple or an orange. And I agree with everything that she said. And so you have to create an environment with the family to allow the seed to grow on its own and not try to make the seed an apple or make the seed an orange so that it becomes clear over time, because some kids are shy and they don't say I wish, they don't say I am, they don't say anything. And we need to help them go from a seed to a fruit.
Thank you. Lynn.
Vâng ạ. Tôi là Hương ạ, tôi làm tham vấn trị liệu tâm lý. Tôi biết là bây giờ cũng khá là muộn rồi mà tôi cũng có trao đổi để tôi có thể đợi đến chiều. Nhưng mà bác ấy nói là tôi có thể hỏi một câu hỏi. Vâng, thực ra là tôi có rất là nhiều câu hỏi nhưng mà nó cũng được trả lời đâu đó ở đây. Thì tôi xin nói ngắn gọn thôi.
Do you want to start with one question at a time?
Vâng.
We'll see how far we go.
Thứ nhất là tôi rất là quan tâm đến cái liệu pháp mà ức chế dậy thì ạ. Tôi làm tham vấn tâm lý và cái nhiệm vụ của tôi là hỗ trợ cho thân chủ có nhiều thông tin nhất để họ đưa ra cái quyết định, có đầy đủ thông tin trước khi đưa ra quyết định. Và tôi rất là băn khoăn việc cái liệu pháp này có rất nhiều lợi ích. Tuy nhiên là cái giai đoạn dậy thì là giai đoạn đang phát triển rất là nhảy vọt. Vậy thì chúng ta trì hoãn cái sự phát triển về mặt hormone, sinh dục, xúc cảm giới tính tình dục. Vậy nó có đồng thời gây ảnh hưởng đến sự phát triển về chiều cao cân nặng hay những cái khía cạnh phát triển khác của trẻ hay không? Vâng. Tôi xin thêm được không ạ? Vì nó đang tiện rồi ạ. Cái thứ hai
is your question, does it affect height and weight of the child, the puberty blockers? Dr. Rosenthal.
Vậy tôi sẽ có thể đợi đến chiều và tôi sẽ hỏi tiếp ạ. Dạ.
That is being studied. We don't know the definitive answer, but we know that a person's, if we talk about the height, we know that a person's adult height is the combination of how much they grow before puberty and how much they grow during the pubertal growth spurt. So if you put somebody on a blocker and you prolong the prepubertal growth period, then it's theoretically possible that they would have a greater adult height. But we really have to study this.
Great. Next question. Your next. Great.
Dạ. Cái câu hỏi số 2 mà tôi muốn chia sẻ đấy là cái mà chúng ta đang ở đây ấy để làm cái việc chăm sóc sức khỏe cho người chuyển giới, làm giảm bức bối rối và tăng cái sự hài lòng trong cuộc sống. Và cái nhiệm vụ bình thường mà chúng tôi làm với cả các quyết định khác ấy là giúp cho thân chủ khám phá bản thân mình để rõ ràng hơn và có cái quyết định mà mang tính được xem xét cân nhắc trên mọi khía cạnh. Và nhà tham vấn thì không chịu trách nhiệm với cái quyết định của thân chủ. Nhưng trong cái lĩnh vực mà đánh giá khi chuyển giới ấy, thì cần theo tôi hiểu là cần có một cái sự chính thống hơn, một quy trình rõ ràng và chính thống hơn rất là nhiều. Vậy thì trong những cái trường hợp mà thân chủ sau khi thực hiện những cái phẫu thuật và điều trị hormone và thân chủ không hài lòng với cái quyết định đấy, thì liệu cái trách nhiệm của cái người làm đánh giá vẫn như thế nào, và liệu có cái khả năng nào một cái người làm đánh giá có thể bị kiện về cái trong cái trường hợp này hay không? Vâng ạ.
So I would say that I don't know the legal policies in Vietnam, and I don't know what, I just don't understand the culture of medical legal issues in Vietnam and what the responsibility of the provider is. My opinion is that if you educate your client, I have 2 points actually. If you educate your client beforehand, and you let them know that they are a person too, okay? That helping their gender identity become more congruent, more the same with their body, is one element of who they are, okay? But it's not everything about who they are, okay? Transgender people are people. They should not only be defined by being transgender. And so it is possible that even after transition, people are still depressed. That's because everybody can become depressed. Everybody can have mental health issues. So as long as you educate your clients that this is one way of helping them, okay, but it's not necessarily going to fix their entire life, okay. And I think that you've provided with them as much information as possible. As long as you say, here's the pros, here's the cons, here's the pros of not doing it, here's the cons of not doing it, and you explore those 4 things, I think you've done your ethical responsibility for the patient.
Steve, did you want to? Oh, Diane?
And another thing, and this is when I work with youth, and I think your question is a good one because we're all a little kind of concerned about our work and helping make these decisions, is that I often ask people to imagine where they see themselves in 5 years, 1 year, 5 years, to then as that a beginning of a dialogue of what they envision, and then to work with them about what's in the realm of reality and what might be unrealistic expectations, and that helps a lot too. One caveat. What we have found is that many of the people who are expressing gender expansiveness are also on another spectrum, and that's the autism spectrum. And so there's another pathway that we are considering because of specific needs, and one of those specific needs is for many people who are on the autism spectrum that they can't answer that question. They can't envision 5 years from now, so we do something else instead for those patients.
I was just going to add that one of the central themes from the standards of care is helping. It's all of our interventions, especially the reversible ones, are to help people find a gender role that they're comfortable with. So hormone therapy is reversible too. People can stop it. And I think that for any of our therapies to be effective, it's, as my colleagues have said, a lot of talking before treatment to set reasonable expectations and cut down unreasonable expectations. And then after starting treatment, to keep checking in and seeing how are things going. Overall, do you feel better in the last 3 months than a year ago while you've been on hormones? How is your sexual function? What is your... you can talk about a million things, but just see how people are doing. And if people are doing well, then they may want to transition more. If they're not sure, don't do anything and wait. So, we just take a cautious approach. I think it's a very reasonable way of doing it.
Thank you. I think we have a question here.
Hello. Let me introduce. My name is Chăm. I'm just a young doctor. I am working as an andrologist. And first of all, I'm very thankful for all the presentation in this morning. And I have a question for Dr. Lawrence. I hear you mention about we have to stop the hormone therapy before the operation. So I want to ask why we have to stop and why the duration is 2 weeks. And if we have to stop the hormone after surgery, how long have we have to start again? And is it the same for the female to male and male to female transgender? And is it the same for all operation?
Thank you. So historically, there's been an association between estrogen and risk of venous thromboembolism. Now, that may be based upon route of administration, etc. Most surgeons still in the U.S. Discontinue hormones for a period of time, anywhere from 2 weeks to a bit more, and resume hormones anywhere from a week, 2 weeks after. There's a movement in the U.S. not to continue hormones throughout surgery, theorizing that the risk of venous thromboembolism is low, and that with current hormonal recommendations, the risk of venous thromboembolism is not elevated. We don't have a definitive answer based on the data to that question. The risks or the reason that we stop is to mitigate, to lower the risk of blood clots, because there are many inciting factors: general anesthesia, pelvic surgery, immobilization. People may travel long distances, so whether airplane, car ride, there may be dehydrated from a bowel prep the night before. Now, so those current, even with that knowledge, it seems to be, the data seem to suggest that the risk of venous thromboembolism after vaginoplasty is quite low. Okay, many people, including ourselves, are looking at that topic more rigorously. Some centers in the U.S. have do not discontinue hormones. However, as I understand, those centers that do not discontinue hormones also do chemoprophylaxis. So at that point, there's the risk also of bleeding, potentially associated with unfractionated or fractionated heparin, for example, in the perioperative period. In plastic surgery, in the States, we use what's called a modified Caprini risk assessment model that adds up these various risk factors for a patient and stratifies them into low, moderate, or high risk patient, and then proposes interventions, whether no prophylaxis, mechanical prophylaxis, or combination of mechanical and chemoprophylaxis. I would say, generally speaking, and Maurice can correct me if I'm wrong, many of the vaginoplasty patients fall almost automatically either into moderate or high risk for VTE, even though the risk of a VTE seems to be low. Now, the issue with testosterone is different. That risk of there hasn't, to my knowledge, been any real demonstrated risk of perioperative VTE with testosterone use. There are anecdotal suggestions, though, that some things, perhaps postoperative bleeding, may be higher in individuals who continue testosterone use, but that's not clear. For the microsurgical procedures, we check blood count because there's a risk of blood viscosity if people are polycythemic, if the hemoglobin is quite high, although we can, during surgery, hemodilute a bit to give them intravenous fluid and dilute their hemoglobin.
I totally agree with everything Dr. Schechter said. I'll add that if you consult the gynecologic literature about pelvic surgery in cis women, the risk of thromboembolism after pelvic surgery is only a little bit higher. But, you know, think of the consequences if someone has, so I like Dr. Schechter, I'll stop hormones for a little period before surgery. I do a week, and I hold it for 3 weeks after. But throughout, patients are getting sub-Q heparin until they're walking. Why? Because it's a short window to stop, and the consequences of getting a VTE can be very horrible. If someone gets a VTE, they have to be on Coumadin, very anticoagulated. The risk of bleeding and losing the vaginal canal goes up, because if there's bleeding between the graft and the vaginal space, the canal space, the graft gets lost. So I tell patients, first of all, like we all keep the constant theme is we talk to our patients and discuss the pros and cons. With every patient, I tell them before surgery, I'd like to do this. This is why. You like being on hormones. It makes you feel well. It's going to cost you to stop for a week, but the benefits outweigh the harm of that. At least we don't increase your risk of a very bad consequence by 1.5% to 2%. We don't know how much higher it is in trans women, but it's unlikely that it's lower than 1.5%.
Thank you. So as we, and I have been asked to ask the panel to give take-home points in two sentences, literally actually, about what their take-home points are about their lecture. Dr. Scott.
Me first.
2 sentences.
Sentence 1. Do not approach each youth and family with the same assumptions, because you will impose your own values onto that person and that family, and you need to create an environment that allows for them to come to their own conclusions. Sentence 2 would be, it takes a team and a village, because there's not one person that has the perspective that gives the answer. Based on all of these questions, we each want to say something, because we have the mental health perspective, the surgical perspective, the medical perspective, and the parent perspective, and the child perspective. So it's a combination of perspectives allows us to get to the answer when we are evaluating the risk benefit of an intervention against the risk benefit of no intervention.
Thank you. Dr. Diane.
So sentence 1, actually I'm going to make it sentence 3, because I probably would have said those two. So sentence 3 is, gender journeys do not start later in life. They start at the beginning of life, and it is really important to be able to have our eyes open to that phenomenon and offer the supports along the way from early onward, and to be able to do that in some continuous way. Sentence number 2 is to remember that we are not working in opposition to families, but with families, and that that's a really important part of the work in terms of making those connections and having dialogues and remembering that the family is part of the interdisciplinary team.
Thank you. Dr. Maurice.
I did not give a lecture, so I will only have one sentence. My colleagues have all made very good points. What I would add is that at the beginning of today's lecture, some of the questions sounded almost very anxious and nervous about providing care. And my advice is, if we talk with our patients a lot and listen, number 1, we will learn a lot as providers. That's how I learned. And number 2, we learn how to treat each individual patient better. And we can keep pace. It's like a dance. We can follow along to help them get to where they want. So don't be afraid, and listen, and they will guide us. They'll teach us what they want and need.
Thank you. Dr. Lauren.
I'll speak in bullet points. So point 1, multidisciplinary care. Point 2, as best we can, understand goals and expectations prior to surgery. And 3, if you and the patient choose to operate, make sure there is a post-operative plan in place that the patient has adequate support following surgery, because that's a critical component of the surgical process.
Thank you so much. I will leave you, thank you to all the presenters, and I will leave you with Brad, because are you going to do a closing and about the So in this session, what we wanted to do is to introduce some different perspectives of how we would work with a client or patient that was coming for surgery. And as the panelists said this morning, we're talking about that it's a conversation that keeps going and going and going, and that we're keeping on revisiting things. But when people go for surgery, these are some of the things that we are considering. So we want to look at how, and we talked about this earlier, Dr. Leibovitz, about treating everyone as an individual, also about providing support, interdisciplinary care, and how can we provide optimal care for people. So as we talked about earlier, people's gender identity, usually if they are going to move forward with a transition, is usually stable for a certain period of time before they want to move forward. And as people go through a transition, there are different aspects that we have to look at and consider. And these are the different, and the people that we have to visit, and areas that we have to look at. So psychological, and we had Dr. Ettner talking about that, Dr. Ehrensaft, Dr. Leibovitz, Dr. Fraser. We also had social aspects as well. Dr. Massey's also a psychologist that talked about that. Hormonal, so we have Dr. Ettner was talking about hormones at lunch. We also had Dr. Rosenthal and Dr. Safer, and surgical. So we have our two surgeons here, Dr. Maurice Garcia and Dr. Lauren Schechter. So these are the different people that are part of the team. People might come in to see you and say, you know, I want to have hormones. But they may not be considering what kind of repercussions those have in their lives, and also how they want to, if they want hormones, are there other things that they need to consider, such as gender marker changes, such as social transition, is surgery a gender affirming goal? So this came up earlier as one of the questions in terms of, you know, interviewing people and asking people, you know, what are your goals in coming to see me? And another part of that is, have you considered this, this, or this? And sometimes people just have this singular view. So it's important to kind of look at the whole landscape. This table was nicely, it's in your handout, and I won't go through it, but it was nicely populated by Dr. Ettner and Dr. Leibovitz when we had our slide review in Chicago. And these are just some of the different areas, it's in your slide set, that we look at when we're looking at psychological areas, social areas, hormones, and surgery. And many of these areas have been explored or talked about by the lecturers thus far. So what are some limitations, though, in providing optimal care? We talked earlier, and it was actually Dr. Diane that talked about this, is that we have been trained for people that have been in this field a long time, that we have this binary assumption to to providing care that a person, if they're assigned female at birth, then if they want to transition, it has to be all the way out to the male spectrum. But now it's more about that there is a gender spectrum, and it's affirming the person's goals. Also in Canada, for example, we have excessive waits to get treatment, to see people, because we have socialized medicine and it's not a private pay system. And sometimes there is limited evidence behind the diagnostic criteria and treatment options. And one of the reasons that we're doing, or one of the main reasons that we're doing the Standards of Care version 8 in an evidence-based way is to say, okay, what evidence exists in these different areas? And finally, sometimes it's hard to access trans care because there's limited knowledge or skill training in the area. And we're hoping with being here that this will start a conversation, and we're learning from you, and hopefully you're learning from us, so that there would be increase in access to care for trans and non-binary people. As Dr. Ettner said earlier, well, actually yesterday, there are barriers to care in that trans people, because of negative experiences, avoid seeking professional help, and because of how they have been treated by the institutions around them and also the medical professionals. In addition, many people, or a lot of people, are on the internet and getting information on the internet, and it's not necessarily the correct information or the most updated information or evidence-based education or resources. One of the questions that we had earlier was about criteria and for hormones and surgery. So this is based on the Standards of Care version 7. And so if people are wanting to move forward with hormones or chest and breast surgery, these are the 4 criteria that are recommended by the WPATH Standards of Care version 7. So 1 is persistent, well-documented gender dysphoria. 2, capacity to consent for treatment. 3, age of majority in a given country. And 4, if you have medical or mental health, if there are medical or mental health concerns, they have to be reasonably well controlled. And you notice on the English version, reasonably is bolded, and that's for a very specific reason. Before I go on to that, I wanted to go back one criteria, age of majority in a given country, because there are, in the WPATH guidelines, different criteria for adolescents in terms of chest surgery and hormones. Not for lower surgery. For lower surgery, it's age of majority in a given country. So let's go to lower surgeries, gonad and genital surgeries. So notice, number 1 is the same in terms of persistent, well-documented gender dysphoria. 2, capacity to consent for treatment. 3, age of majority in a given country. 4, I don't know, notice the difference here. If a person has medical or mental health concerns, if they're present, they have to be well controlled, versus if I go back to the last slide, it's reasonably well controlled. So 5, we add 1 more criteria for gonadectomy, and that's 12 months of hormones. And 6, we add 1 criteria for genital surgery, and that is living in a gender congruent role for 12 months. So when we look at the difference between the upper surgeries and hormones versus lower surgeries, the reason that that number 4 criteria is different is that it's much different in Canada, for example, and the US. Dr. Schechter was talking earlier about this. If you have a breast or chest surgery, it's day surgery. The person leaves the hospital the same day. Versus if you have genital surgery, for phalloplasty, for example, that surgery is usually in multiple stages, and as Dr. Schechter was mentioning, usually the more stages that are involved, the better the outcomes, like the lower the risk. But the other part to consider is the more surgeries you're having, the longer, the more protracted the course is. So you may be having 3 or 4 surgeries over a period of 2 years. 1 to 2 years. So you can see then why the criteria is different in terms of reasonably well controlled versus well controlled. These are being reviewed, and there's going to be a meeting actually in this month in London, and the people that are involved in the assessment piece and the surgery piece are going to be meeting to review these criteria to see whether or not these criteria are valid. And one of the criteria that they're looking at is to see, you know, is there any evidence to suggest that if people live in a gender congruent role for a year, that they do statistically better than people that haven't. So they're going to be reviewing that criteria, and that's going to be part of Standards of Care version 8. So when we're looking at people that are coming in and asking for surgery and want to go forward for surgery, there's 4 different areas that we're looking at. Is the person medically prepared? So for example, the most common one that comes up is smoking. So a lot of times if a person is smoking, that's a contraindication for chest surgery, that the surgeon will want them to quit smoking because of the wound care and the healing. The other part is about fertility options, and the reason that we put this separate is that we want to make a really big point about it, that you shouldn't have to trade transitioning for becoming a parent or having different fertility options. Third, psychologically prepared, and someone had asked a question yesterday about depression. You know, what are some areas that you have to consider in terms of versus being reasonably well controlled or well controlled? A person may have depression, but will be able to have like chest surgery, but if they're very, very, very depressed and can't get out of bed, they're not going to be a good surgical candidate. And finally, practical preparedness, and this is who is going to take you to and from your medical appointments? Who is going to take care of you after the surgery? Who is going to prepare meals for you? All of these different things. Do you have enough money to take time off work? And in some cases, do you have enough money to have the surgery? So these are some of the areas, all of the areas that people in the United States and Canada, that they go over these areas and they are part of the letters that we write when people have surgery that we send to the surgeons. Then we know that the person meets the criteria and has the capacity to consent for treatment. So looking at surgery, these are some of the areas, and one of the ways that we do this is setting out a grid and looking at at different options, that you can even use this working with your clients and saying, you know, do you have any, let's look and map this out and see if there are any concerns in these different areas, and how can we move forward to helping you achieve these goals so you can have surgery and the best surgical outcome. So this is Joe Wong, and he is the director of Asia Pacific Trans Network. So what I'd like to do is I'm going to read the case. It's in English, but it will be translated in Vietnamese. And this is more of an audience participation exercise to begin with. As we go along, and I read out the scenario, I'd like people to put their hands up if they have any concerns as I go along, just so that we're kind of looking at addressing the concerns. So this is a person that wants to have chest surgery. So Teddy Bautista is a bicultural Filipino and white 19-year-old who lives with his mother and father. He is the youngest of 3 children and over 10 years younger than his other siblings. He has saved $6,000 in cash for his chest surgery. He pays in cash when he comes to see you, the surgeons. And he has health insurance from his family, though, but doesn't want to use it. He is returning to see you. You began to see him a year ago when he was severely depressed and still in high school. He is waiting for the moment that he turned 18 and could start hormones. So at that point, or where he was, he had to be 18 to start hormones. He had seen a therapist when he came out as a lesbian, and was participating in a local queer youth group. He decided that he wanted to start hormones with involving his parents because his mother was recently diagnosed with multiple sclerosis. And his father had trouble with the whole lesbian thing. After you referred him to a hormone provider, he came to see you a few months ago and then dropped out of treatment. His depression has improved and his gender dysphoria has decreased. So he hates his breasts and he is binding his breasts. And he likes the way that he looks with the chest binding, but he has asthma and he feels like it's not the best idea. He states his mother is fine with him having hormones as long as he doesn't have surgery. Next, so he came out to his mother as trans when his voice began to drop and he had facial hair. They agreed that it's best that he not tell his father. And Teddy thinks that no one will worry or no one will notice if he has chest surgery. He has been out to his father. He has been out in public with his father, and he's been referred to as he and him. And his father looked puzzled and wasn't happy about this. And with his depression, it's mostly improved, but his hormones have been a bit difficult to manage. And he's lost his job recently as a sales clerk, and his boss was not treating him well. So he's now looking for a job, and in case he gets kicked out of the house, that he'll have a place to stay. Also, he's wondering about his sexual orientation because he's been sexually active with men and also having sexual encounters in the mall. And he's wondering about this. So he has never, in terms of being receptive, he has never liked anyone putting anything in his vagina. And this also made him wonder if he was really a girl after all, after having penetration. But even if that, he wants to have these chesticles removed. So I'm wondering what kind of concerns, if any, you would have in terms of this person having surgery if they were coming in to see you in the United States first.
This is a pretty complex case, and I would seek a few things in order to get a better perspective on this particular patient. One, I would want to have support from a mental health professional in the conflict that this individual has with his parents, with his living situation, and yet his desire not to have breasts. A simple complication that he may not realize is that post-operatively, if he goes against his father's wishes, will anybody take care of him at home? So will he have the appropriate post-op care? So those are some of the practical kinds of things. But as a primary care doc, I certainly would investigate and want to have full disclosure and discussion about what he actually wants, what his hesitancy is to move forward. Clearly, he has the finances to pay for the surgery, but he may not have the finances or the wherewithal to be taken care of post-operatively and be supported. He does not have a job. That's a concern. So as a primary care physician, we're going to be involved in the social aspects, the medical aspects, the physical aspects, and trying to put this all together. So if this individual appeared in my office, I would start from the very beginning as to this individual's gender journey. I would also offer, any services that I would have to be able to have a frank discussion with the resistance of his parents and the division, I guess, between his mother and father. Mother being supportive for hormones and seeing her son now appearing to be masculine, and what is the resistance in having the breast removed. The child is binding, or the adult is binding, and would be a lot better off for a variety of reasons. And these are the reasons that I would emphasize in talking with the parents. The asthma, the restriction of the lung capacity in having this binding 24/7, and the appearance of the individual and his own psychological well-being. So it would be multifaceted, it would be complex, and I would have the ability to be able to consult with people like Dr. Randy Etner, to be able to engage the patient and the family, as well as myself, and give assurances to the surgeon that this was a viable candidate and that they could expect that this individual would meet the criteria that you elicited, those 4 criteria.
Lauren and Maurice, what concerns would you have?
So I would echo Dr. Etner's concerns. I think ultimately it sounds as if this individual is going down the path to surgery, and we want to be able to optimize all conditions around that. He will have to at some point either reconcile the issue with his father and his parents, whether they come to a mutual agreement or whether they don't come to a mutual agreement. And should they not be able to come to a mutual agreement, what are the ways to help him through surgery and ensure a safe post-operative course with the appropriate post-operative support. I think we would hope that they would reach resolution within the family prior to surgery, but that may or may not be possible.
And I think that that's an interesting point, and because he does have capacity to consent for treatment, and he is an adult, so he does meet the criteria. But it's about what the optimum outcome would be. So I think that that's really important, that he does meet criteria for surgery. And the job of the healthcare professionals, the mental health professionals, the primary care doctor, the surgeons, is to provide optimal care and to go beyond what those criteria are. So, Joe, can I ask you from a perspective, I know there's many, many cultures in Asia, but from more of a local perspective, how would this kind of scenario be viewed in Vietnam?
Okay, maybe just a little background about me. So apart from the fact that I'm the director of a regional trans organization, I work a lot with trans individuals who doesn't have access to a health systems or know where to get support. And so bridging the pathways in communications, in finding them a relevant health support that they need for their transitioning journey. So we've had so many of these cases before of trans people who are confused, not knowing where they are. Firstly, knowing themselves coming out as trans person takes lots of time. This case, for example, as a trans masculine person, a trans man, being assigned female at birth and then going through a phase whereby the parents thought they were lesbian, and so it's a very confusing part for any person going through so many thinking processes. And then having a girlfriend that isn't completely understanding or knowing how important it is for the individual to change their body parts so that they feel more attuned to their body and their needs. So whenever we hear such cases, we also wonder, this case, for example, there is no mention about them having significant support from people like themselves. It seems like the word circulated around their family and their partner and them going out, having sex with strangers or people they don't know. And for us who run support groups and community sessions where we listen to what's going on, this is recurring, the fact that they don't quite know where they belong. And wanting to find a sense of belonging through another person and engaging in risky behavior after that. And we think for us, because we are not medical providers, but we think it's necessary to have such support systems within identity groups so that they can share their experiences of navigating the journey. But then again, it's very different from one individual to another depending on their family situation, their income and so on and so forth, and what they have access to and what they don't have access to. So I think like apart from needing to have medical provider support, professional support, it can also be accompanied by community level support so that they can make better decisions, seeing how someone has navigated that system and how it has worked for them. So they're not finding that they could only listen to a health provider who obviously have limited time in seeing them. And again, this is limited to if they have access to that provider and can pay for it. But if not, what other avenues are there? And more people are now going on the internet to get information. While that is dangerous, but we recognize also that this is an emerging thing that is happening now, and we are also penetrating into online spaces and trying to see what's happening there.
Thank you, Joe.
Gail, I just wanted to add one little thing that occurred to me. his situation struck me that he has health insurance but doesn't want to use it and is ready to pay for his surgery in cash. My sense is, although I don't do breast surgery or chest surgery, my sense is that the complications with that are probably limited and wouldn't be could not be an out of control problem, but someone getting a bigger surgery like genital surgery, a more complex surgery, vaginoplasty, people can have very disastrous outcomes. So for people that are dependent on paying cash, I think it's we have to be careful, because if they may have just enough money for the surgery, but if they have a complication, can they afford the complication? I don't feel comfortable doing a big surgery on someone who I know has no access to care after the surgery if it goes wrong or if there's a problem. And I think that should be considered in our health systems. In the United States, if people have, they can go to Thailand or somewhere or anywhere in the States and get surgery for cash, and if they have a problem, there's always somewhere that can help them with insurance. Here, I don't know what the situation is, but we have to think about that.
Thank you, Maurice. Now, Dr. Song, can you tell us if a person wants to access chest surgery, and this person were to, how would they do that here for our learning in Vietnam? Thank you.
Tôi xin trả lời bằng tiếng Việt ạ. Thì thực ra những trường hợp như bạn này trong case study của chúng ta thì ở Việt Nam thì tôi đã gặp rất là nhiều, và tôi cũng đã phải tư vấn cho cả bệnh nhân và cả gia đình nữa. Thế thì nó cũng nằm ở rất nhiều hoàn cảnh, tức là có những trường hợp thì bố mẹ không đồng ý và các bạn ấy đưa bố mẹ đến để nhờ bác sĩ thuyết phục bố mẹ họ đồng ý cho cái việc, cái mong muốn đấy và cái sự phẫu thuật của họ. Thế thì có những trường hợp thì gia đình người ta sẽ gọi từ chối chấp nhận cái bản thân cái người đấy nếu mà họ phẫu thuật, thì nó đẩy các bác sĩ vào một cái tình huống rất là khó xử. Nếu mà không giúp thì họ có thể đến làm ở những cái cơ sở phẫu thuật nó không được đảm bảo, mà giúp thì nó cũng sẽ đặt người bác sĩ vào một cái nguy cơ gặp rất là nhiều vấn đề. Vì ở Việt Nam ấy thì cái sự can thiệp của gia đình vào với cả cái phẫu thuật của bệnh nhân nó rất là lớn. Nó không phải là bệnh nhân có thể tự quyết định được cái chuyện phẫu thuật, mà gia đình sau đấy có thể can thiệp kiện tụng, rồi là gây ra rất là nhiều phiền phức. Và từ đấy thì các bác sĩ ở Việt Nam cũng muốn có một cái sự đồng thuận từ gia đình với cả bệnh nhân, từ đấy thì có thể tạo ra được cái sự điều trị tốt nhất cho cái người bệnh. Thế thì đối với những bệnh nhân như thế này thì tôi nghĩ là cũng nên gửi đến nhờ các chuyên gia tư vấn và các bác sĩ tâm thần để làm rõ cái mong muốn của bệnh nhân. Vì thực ra thì hiện tại cái mong muốn của anh nó cũng chưa được thực sự rõ ràng và chưa được thực sự quyết tâm. Đấy, cho nên là mà ở Việt Nam thì hiện tại cũng còn thiếu rất là nhiều các cái chuyên gia tư vấn như thế.
You have a comment. Thank you. Brad, can we have a mic? A mic. Thanks.
Hello. Tôi xin tiếp lời bác sĩ Sơn. Thật sự như hôm nay có buổi này cũng là lý do. Thật sự một điều chúng ta nên hiểu rằng ở Việt Nam luật pháp chưa cho phép. Chúng ta phải hiểu một rằng là luật chưa cho phép. Cho nên cái buổi tiệc hôm nay nhờ cũng rất nhiều những chuyên gia trong cộng đồng để chúng ta xúc tiến để có một cái luật. Còn tất cả những gì chúng ta làm là chúng ta chữa khiếm khuyết thôi. Chúng ta không có được quyền làm điều này ở Việt Nam. Kể cả những hormone hay những cái thuốc mà mấy bạn đang bàn tán sôi nổi hôm gài, chúng ta cũng không được Bộ Y tế cho phép, trừ những trường hợp nằm ở những dạng bệnh lý. Chúng ta chẩn đoán là dậy thì sớm hay tất cả những bệnh lý gì đó. Ngoài ra về tư vấn tâm lý là được phép. Còn về mặt điều trị là chưa cho phép. Cho nên mới có cái buổi hôm nay để bên vụ pháp chế của Bộ Y tế để xúc tiến là chúng ta sẽ có một cái luật về chuyển giới cho những người chuyển giới tất cả. Cho nên ở Việt Nam thì điều này nói nó chưa có đúng lắm. Chúng ta chuyển nó qua thành một cái dạng bệnh lý. Ví dụ như khiếm khuyết về âm hộ, khiếm khuyết về gì đó, bị thiếu hụt về hormone gì đó, chúng ta để điều trị thôi, chúng ta chưa được làm điều này. Thì cho các chuyên gia hiểu và chúng ta, những nhà xây dựng hoạch định những cái luật hóa từ từ thì để đi vào trong thời gian gần đây nhất. Xin hết.
Thank you. Thank you. Do people have questions in terms of the process about how this would work in the United States or Canada? I have one thing that is different about Canada in that the surgeries are usually covered. And I know that Dr. Maurice was saying that in some states now and in some legislation it is covered, but in most places in Canada it is covered because we have socialized medicine. But do people have questions in general about how this process would work around surgery and the referral, and how this process would play out in the United States or Canada?
Một vấn đề này tôi thấy hồi nãy giờ chưa có bàn ở các chuyên gia là ở trên cái bệnh nhân này là vừa có quan hệ nam nữ luôn. Như vậy chúng ta có điều trị về tâm lý hay hormone trước khi bàn tới vấn đề phẫu thuật hay không? Từ nãy có đưa ra là có quan hệ với cả nam lẫn nữ, thì không biết có phải chính xác hay không. Thì tôi cũng đã thấy có những trường hợp là họ có vừa quan hệ nam vừa quan hệ nữ luôn. Thì những trường hợp như vậy chúng ta sẽ làm gì?
I think that's a great comment and a great question. And Fred, did you want to answer that?
That brings up an excellent point, and I think Joe referred to it in the risky behavior. So as a primary care physician and having this face-to-face encounter with the patient is to really engage the question of risky behaviors and why. And that leads to other psychological issues as well. So engaging a mental health professional would be very, very helpful in this. But certainly as a primary care physician, again, we want to have these behaviors reasonably well controlled. So is it reasonable in risky behaviors to use a condom 90% of the time? I don't think there's a reasonable. No, it's all. You know, that would prevent risk. And so that individual needs to know that and needs to know things like it's possible you could get pregnant because there is still a vagina and ovaries. So I think it's very important before going to surgery that these things are well controlled. So that's an excellent point. I think the difficulties, and you mentioned previously, with law and government, I think throws us as all physicians, we're under the same umbrella. We went into this profession to help people, and we see them face to face. Whether our politicians and our lawmakers do, they're not sitting in that room with that patient. And it's a very difficult position that we're in. So you, physicians, us, we are the vanguard of the well-being of our patients, and ultimately for you as physicians in Vietnam, the well-being of the citizens of Vietnam. And getting the ear of legislators is extremely important to affect this kind of policy and social change.
Thank you. I'm going to make a comment, and I'd like Joe to comment, and Maurice. So Maurice and I have worked many years in sexual medicine and andrology, and so I think it's important to look at the difference between sexual orientation and gender identity, and about who the person is attracted to. And you could be attracted to people of all different genders, but it's more so I don't think that the sexual orientation, that I don't see that as the red flag. It's more about counseling the people in terms of high-risk behaviors. Joe, did you want to say something about that, and Maurice?
That's exactly what I was going to point out, that we have to accept that some people may end up having sex with men and women, or some mixture, you know, some combination, and that's okay, as long as it's the risky behavior that's the issue.
I think I don't know what kind of therapy would be available for someone figuring out like how, you know, like who they might be attracted to sexually. I think really talking through the patient and the behaviors already highlighted earlier, and letting them think for themselves on what are the consequences, because very rarely people do think about the consequences at the time with so many things going on at the back of their head, and it's really breaking them down, helping the clients understand the behavior, and from the medical point of view, like what would be the advice for these behaviors, and they make their own informed decision, and there's really, we don't know what they would do behind the bedrooms, but it's also not our place to police the behaviors.
We have two questions over here. Yep.
Alo, tôi xin muốn hỏi câu hỏi. Hiện tại bây giờ thì đúng như bác sĩ vừa nãy nói là cái Việt Nam mình hiện tại bây giờ chưa có cái luật về phẫu thuật chuyển giới. Bản thân tôi là phẫu thuật viên, cũng là một người mà tham gia cái luật, tham gia dự thảo luật của Bộ Y tế để làm cái luật về chuyển giới cho người chuyển giới. Thì tôi rất quan tâm đến vấn đề là cái phẫu thuật và cái quy trình để cho cái người được chuyển giới người ta thực hiện, và cái mô hình để làm nào set up được cái hệ thống để cho người chuyển giới người ta được một cái từ lúc mà người ta được có cái nguyện vọng chuyển giới đến khi mà người ta được cái sự xác nhận của cái người chuyên gia tâm lý là được cái chuyển giới, đến khi mà điều trị về nội tiết hoặc là phẫu thuật, đến khi chăm sóc phẫu thuật, vân vân, rất nhiều vấn đề. Thì cái mô hình ở các nước như thế nào? Cái mô hình tức là tất cả các chuyên khoa nằm trong một bệnh viện, hay là từ các bệnh viện khác nhau, các cái center khác nhau để chuyển đến và có cái link với nhau để cho một cái người được chuyển giới người ta được thực hiện một cái theo nguyện vọng người ta. Thì tôi muốn mô hình ở Mỹ hoặc ở các nước tiên tiến như thế nào?
Thank you. I think in the States that answer is, it is variable, meaning that in some centers it can be contained within one institution. Others are maybe different practitioners who are not physically located in the same institution. I think, of course, the ability to collaborate can be done by phone, by email, or electronically as well. So I don't think it's mandatory to have everyone under the same roof. I think our European colleagues tend to be more work within an institution where everyone is housed within that institution. Probably in the States and Canada, North America, it's a bit more variable. So multidisciplinary care, I would argue, does not require us to be all in the same physical space.
Thêm một câu hỏi nữa. Maurice, please, Maurice.
Yeah, I totally agree with what Dr. Schechter said. I think perhaps the other part of your question in terms of a standard operating procedure is, what's the flow like? Is that what you mean? From when someone says, I want surgery, to when they get it. And I think we're going to cover that in some of the lectures that are coming, the peri-op, in the planning and documentation sections of our program. But hopefully take this as a reassurance that there are very thoughtful processes that we're happy to share. You may find that you need to do it a little differently, but for me, I have a very good system that I think works and I can explain. But regarding hair removal, stopping hormones, seeing the primary care doctor to have the health checked and everything. There's a place for everything. Other people have figured out, and we're happy to share that with you so that it works well. But it's very doable. Is that clear?
Thank you. But another questions.
Yeah.
Bởi vì ở Việt Nam ấy, tôi thì không phải đại diện cho tất cả mọi người, nhưng mà trong các nước tiên tiến ấy thì hệ thống luật rất là rõ ràng và các cái trách nhiệm chuyên gia đều rất là rõ ràng, và mỗi chuyên gia sẽ có cái trách nhiệm với bản thân và với pháp luật. Thế nhưng mà các nước mà đang phát triển và chưa phát triển chẳng hạn thì cái luật pháp nó chưa rõ ràng. Thế thì cái tình xảy ra này nhiều khi là nếu ở trong một bệnh viện, một cái trung tâm chẳng hạn thì cái người quản lý sẽ điều hành tất cả mọi việc và cái người nhân viên chịu trách nhiệm cho chức lãnh đạo. Thế nhưng mà ở các cái bệnh viện, nếu mà làm khác bệnh viện, khác trung tâm ấy, thì nhiều khi là người ta sẽ không chịu trách nhiệm với ông trách nhiệm với cái ông lãnh đạo bệnh viện này, và người ta nhiều khi người ta refer một cái consent letter, một cái thư gì đấy mà chuyển sang mà người ta không có trách nhiệm nào đó, thì liệu dám mổ hay không?
I would say in the States it's probably more common than not that we see patients who travel far and have primary care physician or mental health professional who are not at our institution. Those are things that are specific regionally and by country in terms of local laws that may be specific to each country. So I'm not as familiar with we're not familiar with the legal system or medical legal system in Vietnam. But in the U.S., just for us, by frame of reference, very common to have primary care physicians and mental health professionals who are not even in the same state, who will provide the various assessments or preoperative work and postoperative care as well.
I can share that I had the same concern when I started a program in Los Angeles where there wasn't an academic program yet. And I was very anxious that I didn't want any problems. So the quality of the letters, sometimes you don't know who wrote the letter, and so I was very concerned about this, and I made a plan that patients with letters that I didn't know, we would have our mental health providers review them. In the end, it hasn't been a problem, and I don't do that. I check the patients myself and double check, but it hasn't been a problem. But that's an approach that you could take at your institution, is have some of your mental health team review letters from people that you don't know. So there's things you can take, and if I can share my experience, with time you start figuring out what works, what's not going to be a problem, and you just keep going. I wouldn't worry so much about it. As long as you have good standards of care and someone is thinking about it, it works out, and if you give good care, it's not a problem.
I also wanted to comment a bit about that. And in terms of the standards of care and letter writing, and we're going to talk about that more in planning and documenting, is to see that all of the criteria are met, and the letter, how the letter is constructed is in accordance to the standards of care, which gives you more reassurance that that person has capacity to consent for treatment. So I hope you come to planning and documenting, because we're going to talk about that for the whole day. Yeah.
Okay. Thank you all.
Thank you.
Yeah.
Go ahead.
I'm sorry.
Sorry. I just.
Go ahead. I'm sorry.
Ha, your last question.
Yes. It's not really a question, but some comment. Mình xin phép chia sẻ bằng tiếng Việt ạ. Thực ra thì là thấy các chuyên gia nhắc đến rất nhiều hai cái khái niệm là bản dạng giới và xu hướng tính dục trong rất nhiều các bài trình bày. Thì thực ra cái kiến thức về SCDI nó không phải là kiến thức phổ biến trong toàn dân hiện nay, chứ đừng nói là các bác sĩ và các y tá. Có lẽ là trong cái tiêu chuẩn chăm sóc dành cho người chuyển giới, bản thứ 7 cũng đã nói đến về phần hỗ trợ người chuyển giới có thể khám phá được bản dạng. Bởi vì cái quá trình khám phá về bản dạng người chuyển giới là một giai đoạn kéo dài gần như suốt cả đời họ. Nên nó không phải là một sớm một chiều mà một bệnh nhân là người chuyển giới đến tìm bác sĩ họ có thể chắc chắn rằng là mình là ai. Bản thân họ nhiều khi cũng gặp khó khăn trong việc trả lời câu hỏi đấy. Nên có thể là cái kiến thức về Soji nên được chia sẻ và nên được trở thành một phần của các cái tập huấn về sau này nếu như mà có những cái buổi như thế này dành cho các bác sĩ. Bởi vì nhiều khi nó là các bác sĩ có thể đặt cho bệnh nhân rất nhiều câu hỏi, nhưng có những cái câu hỏi mà bệnh nhân có thể là không sẵn sàng để trả lời về cái đời sống cá nhân của họ, về việc họ yêu ai và việc họ có quan hệ với ai. Một số những cái khác mà mình có thể thực hành ngay với nhau mà mình không cần đợi phải luật hóa, đó là đôi khi chỉ cần một cái phòng khám nó nhỏ và bác sĩ thân thiện với người chuyển giới, bác sĩ tôn trọng cái nhân xưng của người chuyển giới và bác sĩ tôn trọng câu chuyện và không có can thiệp vào các cái nội dung cá nhân. Và nếu như bác sĩ chỉ cần đạt được những cái tiêu chuẩn đấy thôi là bệnh nhân sẵn sàng bộc lộ những cái vấn đề mà họ đang gặp phải và có thể có những cái buổi trao đổi về cái khó khăn của họ là gì, và bác sĩ có thể offer họ là tôi có thể support về những mảng này. Có một số những cái phòng khám nhỏ ở Hà Nội thì họ đã bắt đầu ứng dụng để tạo ra một cái không gian thân thiện dành cho người chuyển giới bằng việc là sử dụng các cái form, trong đó thì có các cái danh xưng trung tính, các cái tên mà người chuyển giới muốn được gọi. Và cái đấy thì đâu cần phải có luật ạ. Bản thân phòng khám và bệnh viện và bác sĩ cũng có thể bắt đầu thực hành ngay từ bây giờ. Và bản thân các tổ chức của người chuyển giới hiện nay cũng đã có mặt tại Hà Nội, tại thành phố Hồ Chí Minh, và bản thân các tổ chức đó thì cũng đã bắt đầu tiếp cận các bệnh viện để hỏi xem là bệnh viện muốn các tổ chức đồng hành cùng nhau làm gì để cho người chuyển giới có thể tiếp cận các cái dịch vụ không phải là dịch vụ chuyên biệt, nhưng mà ngay cả những cái dịch vụ chăm sóc cơ bản thôi, là khám tổng quát chẳng hạn, thì bản thân người chuyển giới đến bệnh viện trung ương thôi thì cũng đã gặp khó khăn trong việc và bác sĩ không biết gọi người chuyển giới bằng danh xưng nào, và họ dùng cái tên thật của người chuyển giới để gọi họ, thì bản thân cũng đã khó khăn trong cái việc giao tiếp với bác sĩ rồi. Nên đó là những cái thứ mà mình có thể bắt đầu ngay từ bây giờ mà chưa cần phải đợi luật. Just a few comments. I have one question. Trong cái bản tiêu chuẩn thứ 7 thì có nói về phần khám phá bản dạng giới, giúp cho bệnh nhân khám phá về bản dạng giới, hiểu về bản dạng giới, thì muốn hỏi là kinh nghiệm của các chuyên gia thì cái phần hỗ trợ ý hoặc là hỗ trợ cho bệnh nhân khám phá về bản dạng giới của mình thì được áp dụng như thế nào, và có cái phối hợp nào giữa các chuyên gia chăm sóc sức khỏe và các tổ chức cộng đồng trong cái giai đoạn mà cung cấp các cái trợ giúp cho cộng đồng, giúp cho người chuyển giới hiểu về cái bản dạng của mình. Bởi vì có những người chuyển giới họ công khai muộn hơn ở những cái giai đoạn sau, có những người 40-50 tuổi thì mới bắt đầu chuyển giới, có những người công khai từ rất là nhỏ, 5-6 tuổi họ bắt đầu nhận ra bản dạng giới rồi. Thì hiện nay các tổ chức cộng đồng nhận được rất nhiều câu hỏi liên quan đến là câu hỏi liên quan đến việc tôi là ai, và việc là nếu mà tôi có yêu một người, nếu tôi là nữ và tôi yêu một người nữ, nhưng như vậy thì tôi là người đồng tính nữ, nhưng đồng thời tôi cũng muốn cắt bỏ ngực. Vậy thì những cái câu kiểu như vậy thì chúng tôi nhận được rất nhiều. Nhưng mà với những cái câu hỏi phức tạp hơn thì không biết là nên chuyển gửi đến những cái chuyên gia như thế nào. Thì muốn có câu hỏi liên quan đến khám phá bản dạng.
Thank you. Thank you for the information and teaching us and sharing with us. I think those are excellent points in terms of what services are available and to be able to share those services. In terms of when people are coming to see people, that usually people are self-identifying, like if they're coming to see me, for example, in what I do for my work is prepare hormones and surgery letters for people. And so I ask them about their experience about their gender identity, how they identify, what pronouns they use, if they have a name for their gender identity, and their gendered experiences. I think that it's really important what you said in terms of the intake forms, to have what pronouns the person prefers, what name they want to be called. Those types of things I think are really important and very affirming. There are support groups in most of the cities, many of the cities and kind of regional communities in Canada, in terms of people like having support groups either formally organized, and so where there's difficulties in really rural and remote areas, people have better access to care in urban areas.
I have I just wanted to make a point. I think you brought up a nice point that this can start now, before the law, and I think this reminds me of a good, important point to make about trans care, and that is that trans care improves the care of everybody, not just trans people. When we start talking and remembering that everyone has a pronoun, everyone has a sexual identity that may not be what you think because it's a man, he's only with women, or, we just have to assume that you don't know anything about the people that we see, and that we have to treat people never knowing what, so that we're respectful and we don't define them. And that's something that I think contributes to the care of all patients in a medical center. And I think it's one of the reasons why we should be proud, you should be proud, and why I'm proud of taking care of trans people, that it brings out the best in why we're doctors, right? To take care of people and to be respectful.
Thank you. And our next session is going to be at 2:35. Is it a quick question? I hope.
Thật sự thì rất cảm ơn các chuyên gia nãy giờ. Có một câu hỏi. Trước khi hỏi thì thật sự những công việc đã và đang riêng ngành y tế cũng đã thực hiện cách này cũng khoảng 10 năm rồi. Nhưng mà một điều chúng ta hoạt động trong cơ chế không có được cho phép. Giờ mới hỏi bà Lynn Fraser là những cái tổ chức mà trước đây chắc cũng gặp không ít những khó khăn để đạt được, để đấu tranh với những cái cơ quan hiện tại của nước họ để ra được luật hóa để hoạt động cho chính thức, thì họ có kinh nghiệm gì và chỉ cho cái cách đi để cho ở đây cũng có riêng về mặt chuyên môn là y tế, hoặc là các bạn đang đồng hành, ví dụ đang ngồi ở đây là Châu Á, Thái Bình Dương, nhiều hoạt động gì đó để chúng ta đi làm sao cho cái con đường chúng ta đi đến nó nhanh hơn và ngắn hơn và thành công. Và hy vọng lần sau khi mà các chuyên gia ngồi đây là chúng ta đã có một cái luật hẳn hoi rồi, chúng ta bàn sôi nổi về vấn đề chiến lược, nó sẽ đi xa hơn. Ngày hôm nay chúng ta học được rất nhiều. Và riêng này thì nhờ các bạn riêng về ngành mà cái hỗ trợ về cộng đồng và này kia, thì nhờ các bà chuyên gia lớn chia sẻ lại vấn đề để chúng ta đấu tranh, để chúng ta được luật hóa về vấn đề này. Hết.
Thank you. That goes right into your session, Lynn. Did you want to answer that question in terms of at the beginning of your ethics session, or do you want to answer it now?
Can we cut the recording? Yeah. So 2 examples here. I was born in Singapore, and Singapore is considered to be super progressive, systematic, structured. Everything has a process. So in terms of pathways for providing care for a patient, everything is by profession and specialists. So whichever clinic or places that they go to, they would always know where to refer them to. But if not, they just dump them. For example, if a trans person come and get hormones and they don't know who refer, they just dump them into the endocrinology department, and hopefully someone knows where to refer them to. So the Ministry of Health is the one who has the power to convene all providers, all hospitals, to have this discussion about if we receive a case, we must treat the patient. And if you do not know, then you refer them somewhere else. The disadvantage of that is people often are being kicked around the systems, so it's not that perfect after all. And we are in ways very similar to the culture in Vietnam, whereby primarily dominated by society views and perception and attitudes towards the provision of care, and it may create biasness among our providers themselves. So while we have this system, we haven't dealt with the attitudes and perceptions of healthcare provider. And then in Thailand, where I now work and live in for 5 years, I was lucky to have the ability to afford healthcare over there, so I go through a private systems. However, Thailand has always been perceived as a wonderful, inclusive, LGBT-friendly place. There is no legal gender recognition for trans people. There is no law that legalizes trans people in their own countries. But that country opened its door for any trans person from elsewhere to come to get their surgery and be made in Thailand and go back home and be legally recognized. So the complication in Thailand is that every time there is a new election, the laws and policies get thrown out of the window. So if it's passed now with this government, in the next government, there is a possibility that someone will overthrow that law or policy. And we know laws and policy takes lots of time to be implemented or to even go through the drafting process. So in terms of standards of care, there isn't one in Thailand. Despite how progressive, how advanced providing care for trans people are, in private hospitals, the government hospital still doesn't have a standards of care. What they have is networks, and in Asia, mostly, in many places, it relies on networks of providers within their profession to talk to one another. So in Thailand, there is a medical association, and the plastic surgeons get together to talk among themselves, the endocrinologists talk among themselves, but then there is one or two persons who often convene such meetings together for them to talk with each other. And now there is a network of people who develop their own guidance document and their own referral pathways. So they are referring people among their own networks. And I think that's one small step that we can always do until the country is ready to formalize such a step. But then it's the best, it can be considered going through a practice and seeing how that works. And it has worked well in Thailand without a proper legal system. And I wouldn't say legally there is support. There really isn't much support. It is perceived to be supportive, but it is not. So I repeat again, I don't want this documented. For safety reasons, I still have a job in Thailand and I don't want to be kicked out of the country.
Thank you. And so I'd like, thank you, Joe. And thank you for sharing with us. I'd like to thank all of the panel members for joining us and contributing their knowledge and sharing with us. And I would like to invite Dr. Lynn Fraser and Dr. Randy Ettner up for the next session. That we have a beautiful segue into ethics. So thank you so much.
Vâng, xin cảm ơn phần chia sẻ của các bác sĩ ạ. Sau đây sẽ là bài trình bày về các vấn đề về đạo đức của bác sĩ Lynn Fraser và tiến sĩ Randy Ettner ạ.
So, as Dr. Gale was saying, it is a very good segue. I wanted to mention, just in terms of the schedule over the next few days, on day 4, we're going to be doing both planning and documenting, which will be a lot about caring for the transitioning client and the processes from when a person is transitioning in whatever way they are transitioning. But we are also having on day 4 all-day course on ethics, and part of that day will be about having a discussion with you all on the challenges and barriers that you face in terms of ethics and the law. And based on what I'm hearing, many of you are interested in both. So what we wanted to let you know is it's fine to go back and forth so that you'll have an opportunity to participate as much as possible in both courses. Is that clear? Because I know that a lot of the questions, Gail and I were talking about it, how can they learn both? So it'll be by going back and forth, and also have a conversation with us. And one of my key points that I want to make, and Dr. Scott mentioned this as well, is that ethics is a conversation. So that so much of what we want to be doing, particularly in the next few days, is to interact. We'll have more opportunity for interaction. We're so pleased that you have so many questions. And some of the questions, like the question you asked and specifically named me, I can't answer unless I learn more about the situation that you're facing here. And one of the things that is going to happen, which I was mentioning a few minutes ago, is that instead of having complicated cases after our break, we're going to have a panel up here put together. Where's Ha? I don't see. There you are. And Joe. And some other people where some questions, they're putting together some questions where we can all be in dialogue. So I just wanted to let you know. Now moving on to ethical challenges in transgender health, principles and cases. The cases we're going to be doing are mental health. As we talked in the last conversation that we had up here, we had people who were representing surgery and medical care, but not mental health. Mental health was not up here even though we were referred to. Now we'll have only mental health, but we'll be referring to other disciplines. Okay, and it's Dr. Ettner, who you all know. So when we think, oh, one more comment. I wanted to make sure that you all have gotten this questionnaire, questions to consider. Mine is in English, that Dr. Garcia put together, that is Blaine sent to all of you, but you didn't send it? Oh, you haven't sent it? I'm sorry, they don't have it? Can you, yes, make sure that, we want to make sure you all have it for day 4. For day 4, because you were asking questions about, essentially about how to set up your own programs. And what we have in this document in English are the questions to consider. Now, we did it last minute, mostly Dr. Garcia put together the questions to consider, so it's certainly not complete, and we'll be very interested in having you add what you need to this. You'll see what I mean when you get it, but we'll have it for you by day 4 for the ethics, because it's mainly for the ethics course. Okay, I think that's all my announcements. Okay, so we have our primarily textbooks that we use. We have principles of biomedical ethics, and what I'm going to do is talk about what those principles are. And it's an ethical model, and then Randy is going to give some cases and talk about the tensions in the ethical models, and you'll understand. The principles, these are a standard approach to biomedical ethics. What we're talking about, it is, we're taking standard ethics in medicine and applying them to trans health. And it provides a framework to provide any kind of resolution when we're coming up against, we're having a conversation and we may not disagree, or we may not agree, we may disagree. And how do we resolve the concerns? We use this model, and the model, the principles are autonomy, belief in autonomy. I may want the surgeon, if I'm a trans person, to do a particular type of surgery. And it's because it's my body, I have a right for the surgeon to do a particular type of surgery on my body. But the surgeon's position is first do no harm. That means non-maleficence. And sometimes that's intention. Or the surgeon, and I'm not talking just about surgeons right now, but I'm using this as an example. The surgeon wants to do good. And we all want to be fair. So each principle needs to be weighed and balanced in determining an optimal course of action. And you remember when Dr. Scott was talking about what's the truth? And one person may have the truth on this side, another person has the truth on this side. And where is the truth? We need to find some kind of balance. I just said that, but you might want to read it. Still? What? I am. No, but what it's doing, it's going boom, boom, boom. Okay, that's what's happening. It's the remote. It's not, when I'm looking at it, it's going boom, boom, boom, going 3 ahead, 4 ahead, so I need to see if it's on the same. Yeah. If I do on the computer, I think it's probably will work better. Okay, let me see. Where am I now? Yeah. Okay. Oh, that's much better. Thank you. But there are also, when we're talking about morality and ethics, we're talking about the ethics of care. And as doctors, we're all familiar with these. So it's not just the principles that I described. We also have, some of it comes from our heart. Compassion, discernment, trustworthiness, integrity, and conscientiousness. So these virtues can help us when we're grappling with the competing principles. So the virtues are not technical, and they're not based on models or decision-making flowcharts. In other words, again, they come from our heart. A lot of it comes through mentoring. Now, when I'm talking about these virtues, does it sound familiar to the training you get in Vietnam or not? I'm not quite sure what kind of training you have in ethics. It's a question. I'm asking a question. I can't tell. Okay, well, I'll just assume that you have, that it is. So when we think of ethical challenges in WPATH, where do we find the challenges? We find them in policy making. We find them in surgery and interdisciplinary care. We have dilemmas in child and adolescent care. And we also think about it in research and in academic freedom. Sometimes in the West, people can be very excited about their particular point of view when it comes to decision making. And they're not necessarily polite with each other. So in ethics, we want to talk about making sure that the #1 bottom line principle is to listen, even if you don't agree. And I said this before, and I want to say it again. Ethics is a conversation. There's often no right answer. So as we've talked about pretty much all day on the panel, we are an interdisciplinary organization. This is an interdisciplinary field. And how we come to a conclusion of the correct course of action is via a conversation. So I'm going to just I'm going to run through some of these quickly because we're going to have an entire day for those of you who are interested in talking about ethics in this field. And we also want to have a conversation with you about the concerns that come up in Vietnam. But in the United States, we have issues about public restrooms. This has to do with policy making. What restrooms do trans people use in Vietnam when they're in transition? In the United States, we are now having what's called all-gender restrooms, restrooms that anyone can use. I noticed out here we have a male and a female, but if you're trans, do you have a policy regarding what restroom you use, and what are the ethics about that? What about in the workplace? Are trans people discriminated against? Do they have any protections? Or do trans people have to worry about not being able to find work because no one will hire them? Is it legal to cross-dress anywhere or not? Can you be arrested? Also, what about, and hopefully this doesn't happen very often, but what about if a doctor is abusive to a patient because they're trans? Do they have any recourse? These are all ethics. These are considerations ethical about policies. Now, what about surgery? Who decides about an adolescent? I heard just recently somebody was commenting that families are very important in Vietnam. Can an adolescent make a decision about their surgery? What about if non-binary requests? We've been talking about that. Somebody mentioned someone who wanted top surgery without hormones. Is that ethical? What about if the surgeon says, I don't feel comfortable providing that surgery? But who decides? What about someone who wants to detransition? Also, what about, again, someone who is old and has a heart condition, but also is in every other way, meets all the WPATH criteria for surgery? Do they have a right to have surgery? What about somebody who doesn't meet the diagnosis of gender dysphoria, but they still want surgery? These are ethical questions. Surgery. Then we come into child and adolescent gender care. What about with a child wanting services? Dr. Ehrensaft wrote these in terms of respect for autonomy. Her position is you listen to the child. And then in terms of non-maleficence, never do reparative therapy. Do you do reparative therapy in Vietnam? Are there people who want to change their gender identity? Can you change your gender identity? Do they have a right to change their gender identity even if it's possible? Do they have a right to ask us to try to change their gender identity? What is helping and not harming when you're working with children? Does the child have a right to live however they want to in terms of their gender identity, or is it up to society or their parents, for example? And this one is very long, I'm not going to go through it. You can look at this through your, I think we sent all of these out on your slide decks. Dilemmas. Then when you think, and this is the question, and this has to do with power and privilege. I believe, was it Maurice or Dr. Ettner, I can't remember who talked about it, is that who decides who gets to sit at the table in making policies? Is it the providers of care, or do trans people have any right to make decisions about their own lives? What are the ethics of that? Also, what about academic freedom and free speech? Do we have a right as researchers to do research in areas that are considered harmful to trans people? And a comment I just want to end on about WPATH's position is that we recognize that those of us who are in positions of providing care have power and privilege in relationship to the people we serve. And that we need more people who experience gender dysphoria sitting at the table and helping us make decisions about their care.
Do we want a system where the system defines whether you're a man or a woman based on your anatomy? Mm-hmm. So if you're a trans man, do you have to have a phalloplasty to be legally recognized as a man or not?
Yes.
Can you have a metoidioplasty? Can you have just a penis but no urethra and no erectile device, blah, blah, blah? So that was, I think, the interest, that was an important question.
Did you want to say any more about that? Do you have an opinion on that?
Well, I have a very
Maurice?
I have a very strong opinion. Yeah. I don't think the law or social policies should determine whether someone is a man or a woman. I think this is about surgeries that make people's bodies in line with their inner sense of their own gender, and that's all. So phalloplasty, it doesn't matter the details of the surgery, just that people have access to a surgery to make their bodies more in line with who they feel like on the inside. And that's it. I think it's very dangerous when we adopt laws or rules that say, you're only a man if, check, check, check, check. Because someone's not going to fit into that, and I think that's not fair.
And I think that would be consistent with the majority of people who are training here, but it certainly would not be the majority of opinion of a lot of people. And it would be very worth discussing. I'd be very interested in what you're taught in Vietnam, if people have different opinions about that. We're going to move on to some cases that are illustrative of the principles and virtues, and Dr. Ettner will describe them, and then we hopefully have a little bit of time for conversation and a brief break, and then have Ha and Joe come up with whomever else they had in mind.
Thank you, Lynn. I'm going to present a case now that I think illustrates how challenging it can be, particularly for mental health providers who often have the responsibility of making decisions that do involve ethical tensions. So I want to start by telling you about Robert. And Robert is a 68-year-old client who was assigned male at birth, lives as a male, has not transitioned, but has had feelings of gender incongruity and would like to be more female. He's married, he lives with his wife, he has children and grandchildren. He's had some facial surgery, and occasionally he takes hormones. He has resigned to living his life as a male and not transitioning. But he comes to therapy every week, and he feels very comfortable because he knows the therapist understands his longings to be female and his gender issues. Over the past 5 months, I, the therapist, notice that his memory is deteriorating. He's told me the same joke 4 times. The first time, it was funny. The 4th time, not so much. He also seems more depressed, even though he's taking an antidepressant. And he seems to have lost his interest in life and some of his creative endeavors. So he seems very much diminished to me. His functioning is deteriorating. I talk to a psychiatrist, and I believe that he needs to change his medication. And when I talk to Robert about this and ask him to talk to his cardiologist about changing his medication, he keeps forgetting to talk to the cardiologist. So then I ask him, can I talk to the cardiologist? May I contact your cardiologist to discuss this? And he does not want me to. He resists that. Then I ask him if I can speak to his wife about the deterioration in his memory. And he doesn't want me to speak to his wife either. What is my responsibility here? What is my obligation? I want to respect Robert's autonomy, and Lynn has talked about autonomy being an important principle, and yet I want to do what I believe is the right and helpful thing for this client. What do I do? And what would you do if this were your client? So before we move on to the next case, I'd like to ask you, is there anyone here who has a sense of how they would move forward if this were your client?
Ở Việt Nam thì chúng tôi với những cái ca mà nó phức tạp ấy thì chúng tôi luôn có những cái hội chẩn. Thế và ngược lại đặc biệt với các nhà tâm lý thì chúng tôi hay có một cái gọi là cái giám sát, thì là chúng tôi sẽ mời các chuyên gia khác từ bên ngoài đến để có những cái trao đổi đấy, về cái tình trạng về của cái bệnh của cái bệnh nhân như thế này, và để có một cái quyết định chung ạ. Xin cảm ơn ạ.
Tôi sẽ trao đổi với cả Robert về cái vấn đề, cái lý do vì sao mà anh ta không muốn nói, và tôi sẽ trao đổi về cái khó khăn của bản thân mình trong trường hợp những cái gì mà tôi trải qua, những cái lo ngại của tôi và cái hậu quả đó. Và nếu mà anh ta vẫn tiếp tục không muốn nói thì tôi sẽ đặt câu hỏi giả thiết và sẽ nói rằng là nếu mà bây giờ mà tôi cảm thấy là cái việc này nó nguy hiểm đến, nó rất là quan trọng, nó có thể nguy hiểm đến, nó có thể làm hại anh, bởi vì là cái việc cũng cần phải hỏi rõ xem là cái việc mà quên ấy, thì nó đến mức độ nào, nó có thể có nguy cơ gây ra những cái tổn hại về mặt cơ thể hay không. Và tôi sẽ hỏi nghĩa là nếu mà trong trường hợp mà tôi buộc phải làm như thế thì cái mối quan hệ của tôi với anh như thế nào? Và nếu mà trong một số trường hợp mà bệnh nhân sẽ nói rằng là nếu mà anh mà cứ buộc làm như thế thì tôi sẽ không nói chuyện, không làm việc với anh nữa, thì tôi cũng sẽ có thể đặt cho anh câu hỏi là có thể chúng ta sẽ phải kết thúc cái mối quan hệ này, bởi vì là cái mâu thuẫn nó quá lớn và tôi sẽ cảm thấy là sẽ có đến lúc tôi sẽ phải nói cái chuyện này với cả vợ anh, và như thế thì tôi sẽ làm cho anh cảm thấy tổn thương, và anh suy nghĩ như nào về việc đấy, và đó là một cái khả năng xảy ra, và tôi có thể mà chuyển anh đi nơi khác, một người khác xử lý cái tình huống này. Còn sẽ đến lúc mà tôi cảm thấy là tôi không thể handle được cái việc đấy.
I would revisit with Robert his sense of the goals of care with me. How involved does he want me in his care, and what does being involved in his care mean? If it means crossing over the fence to talk to his other doctors about something purely medical, I would say to him, I think that's part of my role, and try to negotiate that with him, because I wouldn't want to stay too passive just because he says no. Well, what does that mean for me? What's my role in all of this?
Right. So I think this illustrates, though, the ethical tensions, because we want to respect the autonomy of the person who doesn't want me intruding. He wants me to stay in my lane. He doesn't want me to talk to other people. And yet I feel that I may have some professional responsibility to reach out to some of these people as I see him deteriorating. Fred, did you have a comment?
I think that you have this long-term relationship with this client, and I think based on that trust that is developed between you and the client, I think he would be receptive to your ultimately speaking with these other professionals. But I think you have to step out of your lane in order to impress upon him, and then run the risk of, as this gentleman said, run the risk of that relationship ending and maybe going to another therapist. But I think he has so much trust in the relationship that he would see this as being helpful for him.
Diane, did you have a comment?
I think this really is a great case around the ethical tensions, because I'm leaning in the direction of not tampering with our therapeutic relationship at all. And that I'm thinking for myself, I'm looking at the issues, I'm imagining that his wife will recognize full well the deterioration. I recognize that there may be an antidepressant that is not recommended. It's not clear, however, whether it's putting his physical health at risk. So I would want to know more about that. And if it wasn't, and it just wasn't appropriate or effective, I might think that the most important thing he would need right now was a private relationship with me, where he felt he had a protected space away from all of those other issues, and could trust that, and so that I might just preserve that and not worry about the other things at the moment, but keep a watch on it.
So I will tell you how I handled this situation, although, as Dr. Lin said, there are no right or wrong answers to these ethical queries. What I did was very much in line with what Diane suggested. The relationship between me and my client is sacred. What I did do, however, because I was concerned about his memory, was I wrote down on a piece of paper the medication that I thought was helpful and that a colleague endorsed. And I handed him that paper, and I said, please show this to your cardiologist, because I had a fear that he was forgetting what I had recommended, and that was part of his resistance. He didn't want to admit to me, oh, I didn't remember what you said. So I wrote that down, but that was as far as I was willing to go, because I really need to keep that trust and that relationship. I would explore with him why he didn't want me to talk with his wife or his cardiologist, but I would never do that without his express permission. So let's move on to another case. Here we have a 41-year-old trans woman, and she's referred to you for a second opinion letter, a referral letter for surgery. She states that she's seeing a counselor, and she's been seeing this counselor for a year, and that counselor has agreed also to write a referral letter. And as you know, according to Standards of Care 7, 2 letters are required for genital reconstructive surgery. But the client tells me that her therapist doesn't know how to write a letter, and so she wants to copy my letter and put it on her letterhead. What ethical principles are in tension here? Obviously, the client wants and needs surgery, and there is autonomy because the client has chosen to see this primary therapist and his relationship with her for over a year. However, what about integrity? Is it fair for someone to just copy my referral letter? So, what do we do in this case? And how do you handle this case when the client has a surgery scheduled and is prepared to proceed to surgery, and yet I'm not willing to just hand my letter over to another therapist to duplicate?
Tôi cho rằng một nhà chuyên môn mà làm công tác đánh giá về cái bức bối rối ấy, cần có cái chứng chỉ, thậm chí tức là phải có được đào tạo. Tức là cái người đấy cần phải biết mình sẽ làm gì, và cái việc mà viết thư giới thiệu chỉ là một phần rất là nhỏ trong cái hoạt động chuyên môn này thôi. Nếu mà tức là có thể có một cái khúc mắc gì đó ở đây, nhưng nếu một người làm chuyên môn mà không có thể làm một cái thao tác nhỏ này ấy, thì tôi còn hoài nghi cả về cái quá trình đánh giá trước, hoặc là thậm chí cái người thân chủ này không đồng ý với cái nhà chuyên môn đấy và đang làm một cái gì đó để hợp thức hóa, để tiến hành thủ tục nhanh, và như thế có thể gây những cái hệ quả mà chúng ta không lường trước được. Và tôi cũng đồng ý với quan điểm này là tôi sẽ từ chối cung cấp cái mẫu này.
Thank you. Refusal. Yes. Anyone else?
Nếu mà chuyện này xảy ra ở Mỹ thì nghe nó hơi buồn cười một tí, nhưng mà trong cái bối cảnh Việt Nam ấy thì tôi nghĩ rằng là nó sẽ hơi khác một tí. Tại vì đa số chúng ta ở đây thì sẽ không biết là cái việc đánh giá nó thực hiện như thế nào. Nếu mà tôi vào rơi tình huống này ấy, thì tôi sẽ đề nghị cái khách hàng đấy là để cái therapist kia contact với tôi và trao đổi. Và bởi vì tôi thì có kinh nghiệm đánh giá, và thì tôi sẽ có thể gửi tài liệu rồi là hướng dẫn cái gì đó cho họ tự làm cái đánh giá đấy. Và nếu mà trong trường hợp khác thì tôi có thể là supervise họ, cho giám sát họ, nhưng mà trong trường hợp này cùng một cây rồi thì chúng ta muốn có hai cái ý kiến độc lập, cho nên là tôi sẽ khuyến khích họ là tìm hiểu rồi là tìm đến những cái người khác nếu có thể để mà hỗ trợ họ. Đó là cái trong cái bối cảnh là cái việc đào tạo của chúng ta nó không được đồng bộ, nó đang rất là thiếu hụt, thì cái việc đấy có thể xảy ra. Nhưng mà nếu mà ở Mỹ như này thì tôi cũng thấy nó hơi buồn cười, hơi lạ.
But here you would be willing to help the therapist and to actually mentor them so they could learn how to do what you know how to do. Yes. So that's an important difference between what's happening here and what we're experiencing. So thank you, that's very helpful to hear. Dr. Gale has a comment.
I think one thing that I'm considering around this is that in terms of the criteria for the second letter is that you have to read the first letter. And so to explain to the client that you're not able to do the second opinion unless, because part of it is reading the first letter and seeing if there's discrepancies and you agree or disagree.
But which one is the first? You can write the first letter and the other person can read the second one.
I think it's a really good question, and you're in a different, because what you're saying is you could mentor that. And if you're wanting to do that and provide that service and that teaching, that's great. But like, I guess my point is a bit different. If they're coming to you with that, that's one of the kind of criteria, but I don't see why you can't work in concert together. But that was my point about what you would say to the client.
Vâng, thì tôi muốn bình luận thêm một chút về cái trường hợp này ấy. Nếu như có cái việc mà cái thao tác viết thư đang gặp khó khăn gì ấy, tại sao không phải là cái nhà trị liệu hay nhà đánh giá đấy liên hệ với cái người giám sát hay là bên chuyên môn của mình để có cái thư này, mà lại là thân chủ là cái người đi đến xin mẫu, thì tôi thấy có một cái bất cập ở đây.
Tôi cũng đồng ý với cái ý kiến của bạn. Bạn ở bên chỗ nào nhỉ? Tại vì tư vấn trị liệu tâm lý. Vừa hôm qua đấy thì tiến sĩ Linh có nói là khi mà mỗi người mà trình bày cái câu hỏi hoặc là nói một cái vấn đề gì đấy thì cố gắng nói về cái tên của mình, cái đơn vị mình làm việc để mình có thể biết rằng là mọi người từ đâu đến và đang làm cái gì. Cảm ơn.
Xin chào bác sĩ Linh và bác sĩ Randy. Tôi tên là Giàu, đến từ Bệnh viện Đại học Dược Cần Thơ. Trước khi mà đóng góp ý kiến về vấn đề này thì tôi có hai nội dung muốn chia sẻ với các bác sĩ. Thứ nhất là về vấn đề y đức. Thì về y đức ở Việt Nam thì trong hai bác sĩ Linh có rất là thì trong Bộ Y tế thì có 12 điều y đức dành cho những nhân viên y tế, bao gồm là bác sĩ, kỹ thuật viên xét nghiệm, về dược, về quản lý trị liệu vân vân, làm theo đức chung. Thì trong quá trình học của ngành y thì vẫn có một bộ môn gọi là đạo đức y khoa, thì nó là một bộ môn chính và được giảng dạy trong ngành y. Thì đồng thời thì cái người thầy mà dạy, người bác sĩ mà người giảng viên dạy thì trong quá trình đào tạo thì họ luôn truyền đạt những cái kiến thức, ngoài ra họ truyền đạt về cái tâm đức của ngành y cho những học viên của họ, học sinh của họ. Đó là vấn đề về y đức luôn luôn được truyền đạt giữa người anh lớn với những người học, những người mà bác sĩ nhỏ hơn. Về thứ hai là về vấn đề về như bác sĩ Dương ở Chợ Đẩy đã nói đó, thì vấn đề về điều trị hormone hoặc là điều trị về phẫu thuật trong về chuyển đổi giới tính ở Việt Nam thì chưa có. Nhưng mà đối với một cái khía cạnh chung là một bác sĩ ngoại khoa thì cái người đại diện cho để mà trước khi một phẫu thuật bất cứ gì đó thì đều giải thích cho bệnh nhân, và chỉ có người bác sĩ giải thích trực tiếp cho người nhà bệnh nhân hoặc là bệnh nhân, không có một người thứ ba đó là luật sư, không có. Thì nếu mà có vấn đề về tranh chấp, nếu mà cái vấn đề cái cuộc mổ xảy ra tốt hết thì ok, không gì đó cả. Nhưng mà nếu cuộc mổ có một số vấn đề bị trục trặc thì một số trường hợp là người nhà bệnh nhân sẽ phàn nàn, thậm chí là tụng kiện rất là lu bu về bác sĩ đó, về bệnh viện đó, về thái độ chăm sóc ở khoa đó, vân vân. Thành ra là chính vì trước khi mà gặp cuộc mổ thì bác sĩ mổ và kết hợp với bác sĩ gây mê sẽ trực tiếp giải thích cho bệnh nhân về vấn đề mổ, những yếu tố nguy cơ trong phẫu thuật, sau mổ yếu tố nguy cơ về gây mê vân vân. Thì người nhà bệnh nhân, thường là người nhà bệnh nhân sẽ ký vào cái tờ giấy cam đoan đó, và nó một cái tờ giấy rất là nhỏ, khoảng tờ A5 thôi hoặc là A4 tùy vào mỗi bệnh viện. nhưng mà nó có một cái form chung Bộ Y tế. Thì sau đó ký xong thì tiến hành cuộc mổ. Thì chỉ đơn giản vậy thôi. Thành ra là những vấn đề về kiện tụng rất là lu bu đối với các bác sĩ Việt Nam. Và cái vấn đề nữa là về vấn đề về giấy giới thiệu. Như trong cái tình huống này thì thật ra ở Việt Nam không có tình huống không có giấy giới thiệu này. Ví dụ một người bệnh nhân, người khách hàng, họ đến muốn làm thẩm mỹ về ngực hoặc là mắt, hoặc là mũi, hoặc là phẫu thuật về bệnh lý như là viêm ruột thừa hoặc là bị gãy xương vân vân, thì chỉ đơn giản là chỉ là cái người đó sẽ giải thích cho cái người bệnh nhân và không có giấy giới thiệu nha, không có giấy giới thiệu của một cái người thứ ba nào cả. Thành ra là khi trong cái tình huống này thì hồi nãy giờ một số bác sĩ cũng ngồi cũng hơi thắc mắc là cái tờ giấy giới thiệu này đâu có, và cũng không biết là của cái cơ quan nào sẽ giới thiệu cho ai và ai sẽ nhận giới thiệu này. Thành ra hồi nãy giờ là em cũng hơi thật sự chưa hiểu về cái tình huống này. Thì dĩ nhiên là rất mong và trong tình huống này thì theo cái quan điểm của em thì đã là giấy giới thiệu rồi thì cái người viết giấy có trách nhiệm với tờ giấy giới thiệu đó của họ. Thành ra là mình không có cái vấn đề về sao chép hay là tôi không biết cách viết, không có. Cái người nào ký tên trong giấy thiệu đó họ có trách nhiệm đối với cái tờ giấy họ giới thiệu.
Those were great comments. What is the standard now for when a patient goes to a surgeon? Do they sign away their rights when they get their prostate removed or their kidney taken out? How does that work? How does informed consent work here? If I'm your patient and you're my surgeon, is it enough that you tell me, well, Maurice, some things may happen that are unexpected and bad. Do you accept those risks? And if I say yes, and then that's okay. You're not, you're okay. How do things work now?
Trả lời cái câu hỏi của Dr. Maurice về cái quy trình mà giải thích trước mổ dành cho các bệnh nhân ở Việt Nam ấy. Thì đầu tiên là bệnh nhân sẽ được các bác sĩ kiểm tra và khám xét rất là kỹ. Sau đấy thì sẽ có một cái cuộc gặp đối với cả bệnh nhân và gia đình để giải thích tất cả về cái tình hình bệnh, cái kế hoạch điều trị, tất cả những cái nguy cơ biến chứng có thể xảy ra. Sau đấy thì bệnh nhân và người nhà sẽ được một khoảng thời gian để suy nghĩ, có thể là một vài ngày, một vài tuần. Sau đấy chúng ta sẽ lên kế hoạch để phẫu thuật. Và trước khi đến cái ngày phẫu thuật thì chúng ta sẽ gặp lại một lần nữa và trao đổi lại những cái thắc mắc mà gia đình và bệnh nhân vẫn còn chưa rõ ràng để thống nhất cái kế hoạch điều trị cuối cùng. Và sẽ có một cái tờ giấy mà bệnh nhân và người nhà sẽ thống nhất là chúng tôi đã hiểu rõ cái kế hoạch điều trị, những cái nguy cơ và có thể xảy ra để hai bên cùng phối hợp và quyết tâm làm việc. Đấy là quy trình làm việc tại Việt Nam. Còn về cái vấn đề mà bạn ấy chưa hiểu về cái việc gửi thư ấy, thế thì về quy trình làm việc ở nước ngoài ấy, đấy là những bệnh nhân mà có nhu cầu về chuyển đổi giới tính, người ta sẽ đến gặp bác sĩ gia đình ở tuyến đầu tiên. Sau đó họ sẽ tư vấn và gửi đến các chuyên gia tâm lý và bác sĩ tâm thần cái thư giới thiệu đấy. Từ đấy khi mà các chuyên gia tâm lý và bác sĩ tâm thần người ta qua cái tư vấn và kiểm tra, người ta tiếp tục gửi thư giới thiệu đến các bác sĩ phẫu thuật. Thì đấy là một cái quá trình liên tục và nó theo từng bước, nó theo quy trình rất là chuẩn rồi và nó rất là đơn giản. Thì đấy là lý do tại sao có cái thư phẫu thuật, thư giới thiệu kia. Thì bạn ấy chưa hiểu. Nên là ở Việt Nam thì hiện tại chúng ta đang xây dựng cái quy trình đấy, và trong cái luật chuyển đổi giới tính mà Bộ Y tế xây dựng ấy, thì nó cũng sẽ bám sát theo cái quy trình đấy để đảm bảo cho mọi việc nó được diễn ra một cách gọi là dễ dàng và đơn giản nhất, và các cái chuyên gia thì cũng không cần thiết phải tập trung tại một cơ sở, mà chúng ta có thể theo một cái biểu mẫu và một quy trình đã thống nhất sẵn và cứ như thế mà làm việc thôi. Đấy.
Thank you. Yes.
Can I just say briefly explain something? Vâng, tôi xin giải thích một chút ạ. Tôi là Minh, tôi là làm tâm lý học và tôi thì là cái người mà làm đánh giá chuyển giới ở Việt Nam. Thì cái thư như anh Sơn nói thì rất là rõ ràng rồi. Tôi chỉ muốn giải thích một chút là vì sao mà chúng ta lại có cái thư đấy. Thì cái phẫu thuật chuyển giới là cái phẫu thuật phức tạp duy nhất mà bác sĩ hoàn toàn dựa vào cái lời tự khai báo của bệnh nhân, đúng không? Tất cả những cái phẫu thuật gì về mình thận, tội phổi, tim, gan, thì chúng ta đều có các cái trắc nghiệm để kiểm tra xem là cái gì. Còn cái này là một phẫu thuật rất lớn, nhưng mà chúng ta chỉ dựa vào lời khai báo của bệnh nhân thôi, và có rất nhiều các cái vấn đề về sức khỏe tâm thần có thể làm cho bệnh nhân ảnh hưởng đến cái quyết định đấy. Và cái phẫu thuật này rất là lớn, nó gây hậu quả lớn, cho nên là có thể bệnh nhân không có biết là cái gì đang chờ đợi mình. Thì tôi có viết một cái bài báo trong hội thảo của Viện Sức khỏe Tâm thần năm ngoái, giải thích lý do là tại sao mà chúng ta lại cần phải đánh giá, thì mọi người có thể tham khảo. Cảm ơn mọi người.
Thank you. And you'll remember that Dr. Gale told us that for this surgery, mental health issues must be well controlled. So the surgeon is relying on the mental health professional because the surgeon doesn't want to make that determination.
I just want to ask a question. Chúng mình ở đây gọi những cái người mà chuyển giới đấy là bệnh nhân, hay là tức là chỉ một cái câu hỏi đối với tất cả những người ngồi ở đây, mà sau này khi mà mình dùng thì mình sẽ dùng những cái từ nào để gọi những cái người đấy? Mình gọi là bệnh nhân hay là mình gọi là khách hàng? Xin mọi người có thể tí nữa có thể cho một cái ý kiến là mình nên gọi họ là ai? Cảm ơn cả nhà.
Thank you. That's an excellent question.
Really good.
I want to make one final comment, and then I'll turn it back to Lynn to close. The way I responded to this request was not so generous, I'm afraid. I told the trans woman that every mental health professional should know how to do an assessment. And that is part of what our training is, learning to do assessments. And if their therapist couldn't do that, then that was an issue for that therapist, and that person should learn how to do a thorough assessment. So thank you for listening and thinking about these complexities. And now I'll put Dr. Lynn on.
Thank you, Dr. Randy. So interesting, and it was so great to see so many people get involved in discussing the ethical issues. One thing I want to make sure is that we get a copy of the ethical principles that are put out by the Ministry of Health here in Vietnam. So do you have access to those? You said that every doctor is trained in, somebody said that, and trained in 8 principles. What were they? Or maybe I misunderstood. But I'd like to get a copy so we can, when we talk about it in day after tomorrow, we'll have the basis from which you are trained, so we can discuss that as well and see what the overlap is. Do you understand my question? Or did I mishear? I did hear. Okay, good. I'd like to have a copy of that. Okay. But thank you so much. And we're going to take a 5-minute break.
Hello.
Yeah. Oh, yeah.
Có cái chị hỏi, thật sự thì cũng cái từ mà chị hỏi cũng đã được bàn luận cũng sôi nổi. Đến thời điểm này thì cũng chưa ngã ngũ được. Ngoài mình phiên dịch cái từ patient từ tiếng Anh ra thì chưa có từ nào. Tại vì làm trong lĩnh vực thẩm mỹ thì một người khách đến họ không có bệnh thì có gọi là bệnh nhân hay khách hàng. Nhưng mà thật ra những chuyên gia đầu ngành thì tất tật đến bác sĩ thì gọi là bệnh nhân. Họ vẫn chưa thống nhất được cái từ này, thì tôi nghĩ là vẫn còn đang bàn thảo tiếp tục chứ vẫn chưa dừng lại đây. Thứ hai nữa, chúng ta bàn rất nhiều về, chúng ta đang đi vòng trong cái khung pháp lý chuyên môn thôi, nhưng mà một lĩnh vực nó rất là ảnh hưởng tới xã hội mà chúng ta chưa thấy. Tôi nói ví dụ thôi, khi chúng ta đặt cái từ bệnh nhân, đã là bệnh nhân, tôi nói ví dụ có một người nào chịu trách nhiệm hình sự khi đã là bệnh nhân thì đã giảm cái hình sự lại, cho nên chúng ta sẽ đụng vào pháp lý tiếp tục về vấn đề này là chúng ta mới được giải quyết nhiều vấn đề. Thì nhưng chắc chắn nó sẽ đi đến một cái con đường nào đó, nhưng có những nhà pháp lý, tôi nói ví dụ cũng có nhiều chuyện lắm trong vấn đề điều trị. Ví dụ người ta muốn cái vấn đề đó, cái vụ án nào đó nó kéo dài hơn, không xử theo đúng cái luật định đó, người ta vô bệnh viện, người ta nằm viện là người ta được quyền quản xử hay vấn đề gì đó nữa. Cho nên chúng ta bàn ở đây là rất nhiều. Cho nên từ mà đã nói là bệnh nhân thì phải có vô viện và có ra viện thì chúng ta được miễn cái đó. Cho nên là cái từ này nó vẫn chưa có thể gọi là khách hàng được, mà nó vẫn còn đối với những nhà chuyên môn nói vẫn là bệnh nhân. Thông báo cho chị vậy là đến hôm nay thì đối với khách hàng thẩm mỹ vẫn là bệnh nhân khi đến, chứ không thể gọi là khách hàng. Tại vì thật sự cái khi mà một vấn đề nào mà nó chạy qua được qua bộ hay chuyên môn thì nó cũng không lọt qua được cái ngôn từ của mấy chuyên gia từ bệnh viện Việt Đức hay là chợ gãy những bệnh viện đầu ngành hết trơn á. Đó là những chia sẻ chung ở đây, hay là những bệnh viện lớn thì giờ vẫn chưa thống nhất là từ bệnh nhân hay là khách hàng. Chắc tiếp tục bàn thảo tiếp trong thời gian tới.
So why don't we make sure that in all of our days, the next 2 days, that in every course we discuss that. What do we call people, patients or clients? And we can talk about how we do it in the United States. It's not as complicated there as here, as it sounds like it. It's a very good question. Okay, I think we can move on. Have a 5-minute break.
I would like to introduce Joe Wong and also Cole Young. Joe Wong is the Executive Director, Program Director, Head of Asia Pacific Trans Network, and Cole Young, who is a Program Officer for Asia Pacific Trans Network. They're going to, through an interactive session, talk about trans rights in terms of Southeast Asia, and also do a survey in terms of what is knowledge and attitudes here in Vietnam with respect to transgender health. So welcome, Joe and Cole. Thank you.
Hello again. Thank you, Gail, for the introductions. Xin chào. And back where I work in, we say Sawadee Cup. So as I briefly said earlier, I work in Bangkok, Thailand. I work with the Asia Pacific Transgender Network. And I thought before we go into our session, which we will be taking you through, Cole and myself will take you through for the next 55 minutes. We promise you that it won't be boring. I know it's close to the end of the day, and I see you are already so good with using your phones, so we will try to make you engage on your mobile phones. So just a little bit about the organization that I represent. Prior to joining the Asia Pacific Transgender Network, which is a regional trans organization based in Bangkok, Thailand, I work in the sexual health programming back home in Singapore, where we work with the Ministry of Health in tailoring programs for men who have sex with men and gay men. And we work very closely with the government in rolling out the IBBS, which you may be familiar with, the behavioral studies among gay men and trans men to control the epidemic of HIV and AIDS in Singapore. And after 4 years there, I moved over to Bangkok and now serve as the executive director of the organization. So APTN is an organization that is 10-year-old now. I think this is our 11th year. It is a trans-led organization, which means to say that lots of the people working in the organization are transgender identified, trans men, trans women, non-binary, gender diverse people working in the organization. And for whatever reasons it is, we decided to set our base in Thailand. Mainly because a lot of development agencies like the United Nations and other programs are based there in Bangkok, Thailand as well, and it facilitates lots of conversation easily if we are based there. Of course, registering the organization is a different story. And these are my team there, just to show you. We are a pretty diverse team, and the representation within the organization is across Asia and the Pacific. The vision of our organization is to uphold respect and protect diversity, safety, equality, and dignity of all trans people across Asia and the Pacific, where we work in. The main focus of our work is increasing funding for trans programming and initiatives, looking into trans people well-being and how to help them decrease burnout in the work that they do, increase representation and leadership of trans people. And the core component of the work we have been doing since the inception of the organization is advancing access to healthcare, legal recognition, and freedom of movement, and advancing human rights of trans people, and generating strategic information that is missing in this region. Some of you may be familiar with freedom of movement among trans people, some may not. For many trans people, traveling from one place to another can be sometimes intimidating. There have been cases of trans women going out of their house in the night and being mistaken as a sex worker and has been harassed on the streets by others who assume that all trans women are sex workers. Or there are people who discriminate against trans people and are violent towards them when they see a trans person walking on the street. Also, it's for those of you who might have the experience of traveling out of the country, going through immigration checkpoints, it can be really traumatizing for a trans person, especially going to the US where you have all those scanners and the pat down by the immigration officer. So that experience itself can be, for a trans person, really difficult. So we're trying to work in that area whereby we're trying to work in an area whereby trans people have enough information before they travel so that they are aware of what they need to know before they go to those places. So I say that we work across Asia and the Pacific, but there are limitations to the country we can work in. In Southeast Asia, we work in all of these countries, and we work in South Asia, East Asia, and currently 5 countries in the Pacific. We currently have 7 active projects, including in Vietnam. And both of these projects are research pieces and working very closely with the health care providers in the provision of care. For the purpose of this foundation training and to introduce the work that our organization do, I will only focus on the healthcare components that our organization has done. So 10 years ago, there was very little information about trans people, their needs, and the barriers of care among trans people. And so we work with several researchers and academics and development agencies such as the United Nations Development Program and UN AIDS to generate strategic information. Of course, recognizing that we cannot do this on our own, we engage and enlist experts that are outside of our community, people who have done such research before to help us gather this data. Then in 2015, one of the really glaring issue and gap is that there is no regional guidance document or any sort of standards of care in our region, Asia. Our focus on Asia. There is no standards of care for this region. And we look towards the global north, in the US, in Europe, on what kind of best practices exist that caters to the needs of trans people, and we look at how it can be adapted to our local context, where family, society, values are of high importance in our region, and then we capture all the best practices among the different countries in Asia and the Pacific to see what kind of lessons can we exchange with one another. This regional guidance document has been reviewed by WPATH, people in WHO, and it's being funded by USAID, PEPFAR, through the PEPFAR support, UNDP, and so on. It's a really comprehensive document, and it's a huge undertaking at the time in 2015 where this document has now has sparked so many conversations around the provision of care when people have not actually thought about that initially. And our aim is to make sure that this addresses and respond to the needs of trans people when it comes to healthcare settings. And I think in 2015, Vietnam passed a law on legal gender recognition, and we're trying to look at access to healthcare in developing this current law that is still not passed yet. And so APTM facilitated a 3-day visit with Mr. Quang, the Director of Legislation and Ministry of Health, with some trans community delegates and a local organization here, where we facilitate these conversations between them and the ministries in Thailand, who is now still drafting the legal gender recognition bill. Okay. So, well, I'm not a medical provider myself, but I do have my fair experience of going through the healthcare systems in many different places. So Thailand is a really, really dear place to me, and part of my body is made in Thailand. And so it's a strange relationship to be working in Thailand and you know, a place where I would only dream of going for surgery, and now actually living and working there and continue to see so many trans people coming into the country. It is very difficult if you don't speak the language. But also if you don't have the post-operative support once you get home. So that has been my journey, going to Thailand at the age of, what, 25? So I have so much respect for you who go through med school during that age and till now may still be studying. I think for me, there wasn't much of an option of studying or working. My goal was to get money for surgery. And so I started working at a really young age. I think I started at 12. This ignorant young person knocking people's door and asking, would you like to buy a Christmas card? In Singapore. So like any jobs I can think of, I was working there trying to save money for surgery. And at my time, I'm 36 now, I think. And at my time, there was no Google also, but luckily there was msn.com or whatever there is, or yahoo.com. But information were very, very scarce and sparse, so you really have to find really hard and dig really hard to get the information that you need. And so most of this information was coming from the US. Of course, I cannot afford to fly to the US to get surgery. And with whatever money that I can save up, I went to the bank and said there is still a shortage in the money that I have, and I would like to take a loan. So by that time, I had a stable job. I could take a loan from the bank. And I got a loan which I spent the next 10 years paying off. But that's not it. I was ready to pay for that money anyway. But what was disappointing was the surgery outcomes. And then at that time, I guess you just get what you get and feel contented that you've gone through surgery. Of course, now I would have different thoughts about that, knowing that patients do have their rights to demand for better care. But although what I shared was almost 10 years ago, these experiences still remains the same for many of the trans people, especially in this region. We have so many Vietnamese coming to Thailand for surgery, and they go to very, very cheap surgeons and coming back with very, very bad infections. And there's no way for them to seek compensation from their health provider, because when they sign, they don't really know what they're signing off. Coming to Thailand, you're signing off forms in English, but like some Vietnamese can't, not just Vietnamese, but people who doesn't have English at their first language doesn't understand what they're signing off on. And So we get so many queries from different trans people asking what can they do? Can they sue the doctor? Can they do this? Can they do that? But their concern more was, what can I do now? I spent all my money on this surgery. And I think someone already mentioned, then what happens now? I think it was Dr. Morris who said it. If you're not part of an insurance plan and you spend all the money you have on that, what happens to post-operative care? And in the community, there's a lot of shame in talking about bad surgery outcomes. There's something about, what is this saying? There's no such thing as cheap and good. You can keep dreaming, but it's not going to happen. So, which is why, like, that experience that I had and seeing what community members go through really keeps me going in thinking why we need to continue bridging this gap and conversation with health providers, because I think health providers are well-meaning people. They just don't know the extent of the damage it does to a trans person when they don't actually think about the possible implication it can have on someone's emotional well-being. Yeah, and that's just a little bit on my journey as a trans person and what compels me to do this work that I do. So, I won't share much more about the organization, but I just want to give you an idea of the available publications that you can see. Just go onto our website, we are aptn.org. If you want to be inspired by some of the possible actions that you can take on, or to even find similarities in your neighboring countries on the issues, these are key documents that you can look at as a reference. Recently, in 2017-18, we mapped out the availability of services in Vietnam, and we found that basic services are available. However, the more comprehensive care is not. So when I say basic services, it's mostly sexual reproductive health services on a very binary note. And also HIV services are widely available if people know where to go access them. In 2017, we convened a huge forum of over 150 delegates over 10 countries, where for the first time we had health providers, National Human Rights Commission institution, policymaker, government people, and the community coming together to talk about their different opinions on why they cannot afford care or why certain policies could not be pushed for. And from there, we started rolling out a series of trans health training across the countries in Asia Pacific, but we also started identifying and see where the gaps are in terms of research. And that's why in Vietnam, we have just completed a research on the barriers in accessing healthcare and the knowledge of healthcare providers working in this area. So that's just the brief introduction about the organization, myself, and we really wanted to know you a bit more. Over this 1.5 days, we haven't really got to hear who you are and what you do and what you're passionate about, and we want to make use of this time that we have to get to know you better. I'll hand this off to KHauE to lead us in the next session.
All right, hello everybody. My name is KHauE. I am from the United States, but I also work in Bangkok. I am a program officer with the Asia Pacific Transgender Network. I used to be a teacher, so I'm all about interactive lessons. So we are going to be doing an interactive participatory activity. As Joe said, we want to hear more about you and your current understanding of trans issues, your current beliefs and opinions. And these information that we gather from you will help us in the development of documents and of trainings and things like that. So if everybody could go to minty.com, I'm sure you have smartphones or even laptops, minty.com, and then enter the number that is up at the top of the screen, 281990. And then when you log in, we already have a few, click yes, so we know that you are able to log in. If you need help, please raise your hand. So fast. No space. You will answer the questions. So I will ask the questions and you can. Okay, I'll be with you. You want that? Do we still need a minute? Thank you. Yeah, just shout at me. I like your participation. So many. Not enough. Please look up at me when you are finished. Show me. Pins down when you're finished writing. Teacher. Yeah. How do we move on? Do we just hit the next? We just hit the next. Once we hit 50, we can move, and then the rest we'll try and log in still. I was about to call out. Does Dr. Maurice need help with technology? Did you hear that? Wait for the presentation. We hit 50. Ready? All right. We're still trying to log in against the login. Maybe raise our hand who needs help. Does anybody need help logging in? One. Okay. It's slow.
Vâng, có anh chị nào chưa đăng nhập vào được và cần trợ giúp không ạ?
Okay, we will move on, but you can still, if you are not logged in yet, you can still log in as we move to the questions. So the first question, how are you feeling now? Are you happy, scared, excited, confused, or sleepy? Oh no, a lot of sleepy. One confused. No one is scared yet. That's good.
We should have 51-ish. Confused.
About 10 more. There's 53.
Free coffee for them.
Yes, there is coffee if you are sleepy. Maybe. We'll go with 2 more and then we will move on. Okay, great. So most people are happy and excited. I love that. A few people are sleepy. Hopefully you wake up during this session. All right, so some demographic questions just so we can get to know you a little bit more. What is your age?
Did you realize the 25 to 31 was so quick?
Yeah.
They were like...
They're ready.
Also, we won't know who answers these questions.
just so you know, these questions, though we can see everybody's answers here, they are anonymous. So no one will know who you are and what your answer is. All right, lots of young people. Moving on, or they're lying. What is your gender identity? So we have cisgender man or cisgender woman. Oh, there you go. The other options are transgender man, transgender woman, non-binary, gender non-conforming, or other. All right, moving on. What is your sex at birth? Your sex assigned at birth. So fast. All right. And last demographic question, what is your sexual orientation? Oh no. Oh no. I don't know the order. Can someone translate? There we go. I just gotta guess.
I guess the red one is straight.
Straight.
Bisexual is
Okay, thank you for the help. All right, so we're going to move on and start talking about the trans community and what you know about the trans community. So the first question is, how many trans people have you met? It's not zero. Awesome. So a majority of people have met more than 10 trans people, which is great. And then some people said, I don't know if I've met a trans person. And that's true. It's not probably zero. You just may not know that somebody is transgender. Awesome. All right. How do you feel about trans people? So here you will type your message. You can type in Vietnamese, and then we will have hopefully some people to help translate for us. if you are not from Vietnam, in your answer, can you put where you are from?
For those who are also English speaking like we are, the translator is translating the Vietnamese text on the screen. Yeah, in general, I think people feel positive about trans people. And some people still don't know a lot about trans people, and so do not have a strong opinion, which is good. I think the fact that you are here shows that you are learning, and hopefully this opinion changes over time. Is there anybody who would like to comment or feedback on what you've seen from the responses? If not, we can move on to the next one. There are going to be lots of questions to reflect on anyway. Okay, moving on.
What words are often associated with transgender people? So these are things that you hear probably from society. Just please pick one word and it will form sort of a word web or a word cloud.
You can submit up to 3 words, but 1 word at a time.
What do you think when you hear transgender?
So when someone says trans person, what's the first thing that comes to your mind? Or what have you heard about trans people? Words that are often associated with them. For example, sex worker, which we often hear being associated with trans women. Yes, just trans. We can wait till like we have 50 responses and then we look at the biggest one.
We have so many more people now. Oh, because they can type sometimes.
So from what I'm hearing from the translation, lots of people are saying that trans people are brave, not straight, which is also gay in the English sense. And then there are lots of LGBTQ. People are putting in different acronyms: LGBT, LGBTQ, LGBTQI. And as you see the words, the bigger ones are what lots of you are putting in. If more people are saying the same thing, it gets bigger. But because we are doing this in 2 languages, we don't see the effect of it, but there are lots of similarity. And mostly the top 3 would be brave, gay, and capable? Bon? Not straight. Wow, there are 72 people that responded to this question.
Okay, thank you, and moving on. So now we are going to start talking more about legal and rights. So here we go. Let's try to make it bigger, 1 second. Should trans people, there we go. Should trans people be allowed to live authentically in their affirmed gender? So the first answer is yes, without medical requirement. The second is yes, with some medical support. The third is yes, if they are on hormones. Yes, if they have complete surgeries and hormones. And last one, no, even if they transition medically.
So for those who have answered, we'd like to get some reflections from the floor. Whatever your answer is, and if you are comfortable saying what it is, we'd like to hear some reflections on those who have mentioned either yes without medical requirements, those who have said yes, some medical support, and particularly also especially those who said yes if they have completed all surgeries and hormones. We can take 2 reflections from the floor. Okay.
Theo tôi thì chúng ta đã tôn trọng họ như tất cả những người khác ấy. Thế vậy và thì sẽ không có bàn luận cái việc cho phép hay không. Cái thứ hai là nếu bức bối giới là vấn đề của cá nhân. Cho nên là cái việc nếu như một người mà người ta cảm thấy thoải mái, nếu người ta không phẫu thuật, không điều trị hormone thì đấy là lựa chọn của cá nhân họ. Và nếu chúng ta tôn trọng và chấp nhận họ thì chúng ta sẽ không cần phải ép buộc họ nhất định là cần phải thực hiện thủ thuật hay là cái điều trị nào thì mới công nhận họ. Vâng.
Come on, thanks for your reflection. Anyone else? Sorry.
Thì theo tôi nghĩ là có thể là mình nên có hỗ trợ về y tế. Y tế đây là mặt cái chung luôn chứ không phải là về phẫu thuật. Ví dụ như về tham vấn về của bác sĩ về tâm lý để mà hỗ trợ họ trong cái sức khỏe của họ thì tôi nghĩ sẽ tốt hơn. Cảm ơn.
And what about like any person from the faculty? Do you have any reflections? Yes.
So my best hope was if we clarified that the medical interventions excluded psychotherapy, that the yellows would turn to blues.
Okay, moving on. Is Vietnamese society ready to legally recognize trans people? So blue is ready, yellow, I don't know, and the last one, not yet.
So while you're filling up your answers, also we'd like to hear your thoughts about this. And if you said ready, why do you think that? If you say no, why is that? And if you don't know, what will make you know?
Just get one from each.
Co say only one for each.
For each, if we can get at least one from each.
No, we can't see what your responses is. That's fine. Yeah. We can't see who said no, yes, I don't know. But when you stand up and share your reflection, we would all know what your answer was. Okay, there are 2. You, is it? No?
Tôi nghĩ là chúng ta đã đủ khả năng để mà chúng ta đã đủ sẵn sàng để mà chấp nhận thừa nhận quyền hợp pháp của người chuyển giới. Một trong những cái bận tâm mà tôi hay nghe thấy khi mà đi tham gia với Bộ Y tế hay là các cái tổ chức đấy là không biết là nếu mà bây giờ cho phép thì chúng ta đã có đủ điều kiện, đủ những nhà tâm lý để đánh giá, đủ các cái cơ sở để phẫu thuật cho họ hay không. Thì tất cả những cái này nó khi mà chúng ta làm thì chúng ta sẽ phát triển, và nếu mà chúng ta làm thì không bao giờ, nếu mà chúng ta không làm thì không bao giờ chúng ta có được những cái đấy. Ví dụ như là đánh giá tâm lý về cái lĩnh vực của tôi chẳng hạn. Nếu mà chúng ta không được chấp nhận thì một năm tôi chắc có được khoảng 1-2 người để đánh giá với mình, bởi vì là tất cả mọi người không có nhu cầu, mọi người có thể sang Thái Lan để làm vì là ở bên đấy có dịch vụ. Nhưng mà chúng ta có những nhà tâm lý, có những nhà bác sĩ tâm thần học, rồi rất là nhiều người sẵn sàng. Có điều cái lĩnh vực này là lĩnh vực mới và chúng ta chưa có kinh nghiệm thì chúng ta sẽ làm.
And who said no, not yet, and would like, don't mind this room knowing that you say no, not yet. There is no right, no wrong answers. It is your opinion, and we would love to learn more about where that perspective or that why you say what you did, why you say what you said. Basically, there is no right or wrong answer. This is not a competition. And I heard that medical doctors can be very competitive. Would anyone love to share further? No, not yet. Okay, see someone.
Em xin tự giới thiệu, em là Hải Anh, em làm trong lĩnh vực tâm lý và em cũng tham gia với một chương trình fellowship ở bên trung tâm sức khỏe Trung tâm sáng kiến sức khỏe và dân số thì cũng là may mắn em được biết hơn về các cái quá trình vận động về chính sách và luật ở nước mình, và có lẽ là ở nhiều nước khác nhau thì cái quá trình vận động thì nó cũng bao gồm nhiều các cái bước khác nhau, và để theo đuổi một cái chính sách hay luật có thể cần rất là nhiều thời gian. Thế thì câu chuyện mỗi khi mà một cái luật gì đấy, kể cả mọi người biết là ở trong các cái vấn đề liên quan đến việc xâm hại trẻ em thì nó vẫn còn đang có một cái lỗ hổng tuổi của mình, đấy là từ 16 đến 18. Thế thì câu chuyện là mình đưa ra cái này lâu rồi nhưng mà luôn được nhận phản hồi về việc là nó còn liên quan đến các cái ngân sách nhà nước, rồi các cái nghiên cứu về việc là điều này đang ảnh hưởng đến bao nhiêu người, liệu đưa ra cái điều này thì nó có tác động đến bao nhiêu người và có gây các ảnh hưởng gì khác không. Thế thì câu chuyện là em nghĩ rằng cái điều này cần thiết, nó chỉ là mình có thể là mình sẽ cần thêm những cái vận động xã hội. Tại vì cái vận động xã hội với cả vận động chính sách thì nó có thể diễn ra song song, thì em nghĩ rằng nó là một cái sự kiểu support rất là hợp lý ở thời điểm hiện tại, bởi vì như mọi người thấy đây là một cái chương trình tập huấn mà khán phòng của chúng ta vẫn còn rất là nhiều ghế, nhưng mà thực ra thì số người đến đây và thì nó cũng chưa nhiều lắm. Và ví dụ như trong hôm nay có bạn là Hà đại diện cho các bạn chuyển giới nam, tuy nhiên ở ít nhất em biết ở Hà Nội có 2 nhóm chuyển giới nữ hoạt động song hành với nhau, nhưng hôm nay không có đại diện của 2 nhóm chuyển giới nữ chẳng hạn. Thì ý em là các cái mình có thể thêm vào đấy các cái làm mạnh hơn các cái vận động xã hội ở thời điểm hiện tại, bởi vì nó thuận lợi và dễ, và đặc biệt là các bạn trẻ thì có nguồn lực hơn so với việc vận động chính sách mà một cái gì đấy dài lâu.
Okay, thank you. And moving on. Laws and policy development should always be done in consultation with trans people themselves. The first answer is yes, alongside technical experts such as healthcare providers, lawyers, or lawmakers. I don't know, or no, we are the experts on the issue. Wow, so positive. 45 people saying, yes, with technical experts. There is one who said, no, we are the experts on the issue. I won't call out on you. One person say, I don't know.
So as a best practice throughout like what we've seen in this region, the ones that are progressive now, like in Nepal, in India, in Sri Lanka, the progressive policies and laws that have been put in place are often done in consultation with trans people. Of course, we recognize the different expertise needed. However, because this impacts and involves the life of a trans person, which is why we often try to encourage and advocate that people who are in a power position, a position of making decisions, include trans people in these discussions. Ultimately, the decision lies with the policymakers and whoever's drafting out the laws. However, listening to the needs and how this would address the concerns of trans people will make this policy or law more effective during the implementation. And there are some good practices that are being carried out now in some countries. Where are they? So in Sri Lanka, already they are thinking about how to include them as part of their budget. Someone brought up budget earlier. And so the government is actually setting aside budgets within their public hospital and government-funded hospital to have these trainings for their health providers, and also offering some free services for trans people to get access to. Yeah, that's one example. Right? And in Thailand, although there is no legal gender recognition, however, they are very concerned about healthcare, and so the they are thinking of including HRT, hormones replacement therapy, as part of the national coverage, the health coverage in their insurance. This is their discussion now. So that example shows that while legally they cannot change their gender, they are making other progress in other ways. Just not legalizing gender recognition yet. I think we can move on. Yeah.
Next question. What role should medical institutions play in the implementation of the new trans law?
So for the English one, someone said be part of the consultation process. Medical institutions can release position statement and declare policy in their mission statement. They should be involved as long as they are gender affirmative. Facilitate implementation of rights of trans people to live authentically. Someone is translating this to Vietnamese, right? Yeah. Yeah, you can read from here. Yeah, please.
Okay, we actually are out of time, so you don't have to answer the question. I just wanted to say thank you for your honesty and your thoughts. This really helps us in understanding the current situation here, and we can help develop documents and guidance. Of course, we are not medical providers, but we work with community and we can build a bridge between community and healthcare providers. So it's really inspirational, and I'm really grateful to be here and grateful that all of you are here to learn how to better help the trans community.
And also, like, the point of this exercise is to find out like what you know and what you don't know and what you think can be done and how you would like to actually get involved. And here we work with SCDI quite closely in terms of the implementation, and this would help guide the next step on how and where we should be putting in more efforts into. And also regionally and globally, like connecting you with experts who knows of this issue, and knowing you here means that we can start involving you and including you more in global or regional conversations around healthcare, so you could learn from others who are experiencing the same dilemma as you are.